Adapun tindak lanjut, yang pertama tenaga kesehatan khususnya nutrisionis, dietitian, dan ATLM dapat menyampaikan edukasi kepada masyarakat terkait protokol kesehatan untuk melawan COVID-19, menetralkan hoax dan informasi yang keliru, serta mendukung masyarakat untuk berpartisipasi aktif dalam pencegahan dan penanganan COVID-19. Nutrisionis, dietitian, dan ATLM dapat memberikan pelayanan kesehatan yang tepat dan sesuai dengan protokol kesehatan pada saat perawat pasien, dan bagi pengurus organisasi profesi PERSAGI dan PATELKI dapat merumuskan suatu rencana program kegiatan bagi nutrisionis, dietitian, dan ATLM yang bertujuan meningkatkan kompetensi mereka dalam memberikan pelayanan kesehatan berkualitas pada masyarakat. Demikian laporan Ibu Dirjen yang bisa kami sampaikan. Tentu selanjutnya kami mohon Ibu dapat membuka dan memberikan arahan pada acara kali ini. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh. Ya.
Terima kasih Bapak. Selanjutnya sambutan dan pembukaan acara webinar oleh Direktur Jenderal Tenaga Kesehatan Dr. Gigi Arianti Anaya MKM. Kepada Ibu kami persilakan.
Terima kasih Mbak Raras. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera.
Waalaikumsalam warahmatullahi wabarakatuh.
Yang saya hormati Bapak Sekretaris KTKI, Pak Budi, Sekretaris Direktorat Jenderal Tenaga Kesehatan, para pimpinan tinggi Madya dan Pratama, Persatuan Ahli Gizi Indonesia, Ketua Umum Persatuan Ahli Teknologi Laboratorium Medik Indonesia, para narasumber, para hadirin yang saya hormati. Tentunya pertama-tama marilah kita panjatkan puji syukur kehadirat Allah Subhanahu wa taala, Tuhan Yang Maha Esa. Pada pagi hari ini kita diberikan nikmat sehat sehingga kita bisa bersama-sama mengikuti acara webinar dengan tema Peran Organisasi Profesi dalam Tindak Lanjut Kebijakan Kementerian Kesehatan terkait pandemi COVID-19. Dan tentunya melihat jumlah peserta partisipan yang luar biasa ya, sudah mencapai 1.000, tentunya apresiasi yang luar biasa. Dan tentu kita berharap walaupun webinar ini dilakukan secara daring, tetapi bisa memberikan manfaat untuk teman-teman semua. Bapak Ibu, para undangan dan para narasumber serta para hadirin yang terhormat, tentunya kita tahu bahwa kita saat ini masih dalam kondisi pandemi COVID-19. Dan tentunya kita berharap segera kita bisa keluar dari kondisi pandemi, kemudian kita bisa merubah status pandemi menjadi endemi, tentunya dengan berbagai persyaratan-persyaratan yang harus dipenuhi sebelum kita bisa merubah status pandemi ini. Tentunya berbagai hal upaya harus kita lakukan untuk mengatasi dan mencegah dan mengendalikan virus COVID-19 ini. Dan pemerintah juga telah membuat berbagai kebijakan sebagai upaya perlindungan kesehatan masyarakat terhadap dampak dari atau penularan dari COVID-19, dan juga berbagai upaya lainnya yang dilakukan agar masyarakat tetap bisa produktif dan bisa melaksanakan aktivitasnya, sehingga tentunya akan mendukung roda perekonomian yang saat ini juga sangat terganggu dengan adanya pandemi COVID-19, dan ini tentunya tidak hanya di Indonesia tetapi juga secara global. Nah, upaya pencegahan dan pengendalian COVID-19 tentunya merupakan bagian dari kebijakan yang harus dilakukan oleh Kementerian Kesehatan khususnya ya, dengan bekerja sama dengan kementerian-kementerian lain, dan tentu saja harus bekerja sama dengan stakeholder, termasuk di dalamnya adalah organisasi profesi ya yang mempunyai penularan yang berbeda dengan varian-varian sebelumnya. Walaupun disampaikan bahwa varian ini memang tidak menimbulkan atau kecil untuk jatuh ke dalam kondisi berat, tetapi tentunya dengan penyebaran atau kemampuan penularan yang luar biasa tingginya, tentunya ini juga merupakan hal yang perlu diperhatikan ya dan dikondisikan dengan baik. Nah, varian Omicron ini tentunya mempunyai cara kerja yang berbeda, di mana menyebabkan penurunan kemampuan kekebalan dan efektivitas vaksin ya, dan tentunya hal ini menyebabkan proses penularan yang cukup tinggi. Di Indonesia varian Omicron pertama kali ditemukan 16 Desember 2021. Tentunya pemerintah telah melakukan berbagai upaya untuk pencegahan, termasuk mendorong masyarakat untuk segera menyelesaikan kewajibannya atau tanggung jawabnya untuk segera melakukan vaksinasi agar tentunya kita bisa segera memutus mata rantai penularan. Walaupun varian Omicron ini dianggap bisa menurunkan kemampuan antibodi yang ada, tetapi dengan proses vaksinasi yang kita lakukan, ya dosis pertama, kedua, dan sekarang kita sedang mengejar dosis ketiga, maka diharapkan kalaupun kita terkena, maka gejala yang kita dapat adalah gejala yang ringan, sehingga kita berharap tingkat kematian juga menjadi lebih rendah. Bapak Ibu, berbagai hal harus kita lakukan ya, yaitu mencegah penularan dengan memberikan edukasi kepada masyarakat, termasuk di dalamnya tenaga kesehatan, gizi dan ahli teknologi laboratorium medik ya, untuk bisa bersama-sama membantu pemerintah menciptakan lingkungan yang aman ya, baik untuk pasien dan petugas lainnya. Tenaga kesehatan gizi dan ahli teknologi laboratorium medik tentunya dapat memberikan informasi terkait pelayanan yang diberikan di masa pandemi melalui edukasi kepada pasien secara intensif ya. Kalau ahli gizi tentunya perlu memberikan edukasi kepada masyarakat bagaimana kita bisa hidup sehat sehingga mencegah khususnya untuk terkait makanan atau minuman yang harus dikonsumsi dengan baik sehingga meningkatkan kekebalan tubuh, mencegah proses penularan ya, karena salah satu penyebab penularan adalah daya tahan tubuh yang menurun. Kemudian juga tentunya kepada tenaga ATLM ini memiliki peran penting karena selain vaksinasi dan protokol kesehatan, maka tracing dan testing adalah hal yang merupakan hal yang penting yang harus dilakukan untuk memutus rantai penularan semakin lagi. Terkait pandemi, tentunya kita berharap peran serta tenaga kesehatan gizi dan ahli teknologi laboratorium medik terus ditingkatkan ya sesuai dengan perannya, juga ikut melakukan edukasi ke masyarakat dan memberikan informasi pencegahan COVID kepada masyarakat, mensosialisasi perilaku hidup sehat ya dan bersih ya. Kemudian tentunya membantu pemerintah untuk meluruskan semua berita-berita hoax ya yang beredar di masyarakat. Nah, Bapak Ibu, memang kita perlu berbesar hati ya, bersyukur karena kelihatannya kasus pandemi semakin turun ya, kasus penularan insiden terhadap COVID-19 ini semakin menurun. Beberapa daerah sudah masuk ke PPKM level 1 walaupun Jakarta masih ke level 2. Oleh karena itu tentunya khususnya para teman-teman semua yang hadir, saya terus mengharapkan agar kita jangan lengah, jangan bosan untuk terus melakukan protokol kesehatan dan terus melakukan edukasi kepada masyarakat. Saya sangat menyambut baik webinar dengan tema Peran Organisasi Profesi dalam Tindak Lanjut Kebijakan Kementerian Kesehatan terkait penanganan COVID-19 sebagai salah satu upaya untuk membangun kepercayaan publik terhadap kesiapsiagaan tenaga kesehatan dan pemerintah dalam mengatasi pandemi COVID-19. Tentu atas nama pemerintah, kami sangat berterima kasih kepada organisasi profesi yang terus bergandeng tangan bersama pemerintah menyelesaikan semua permasalahan kesehatan. Semoga para peserta tenaga kesehatan gizi dan ahli teknologi ini dapat mengikuti acara webinar dengan baik ya, secara aktif untuk meningkatkan pengetahuan dan kompetensinya sehingga dapat memberikan pelayanan yang terbaik untuk masyarakat di masa pandemi maupun di masa-masa berikutnya. Untuk itu, dengan mengucapkan Bismillahirrahmanirrahim, saya buka acara webinar Peran Organisasi Profesi dalam Tindak Lanjut Kebijakan Kementerian Kesehatan terkait penanganan COVID-19 secara resmi. Demikian, wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Terima kasih Bu Dirjen. Terima kasih.
Terima kasih Bu Dirjen atas sambutan, arahan, dan juga pembukaan acara webinar hari ini. Selanjutnya, Bapak Ibu, demi kelancaran rangkaian acara hari ini, marilah kita berdoa agar kegiatan ini mendapatkan keberkahan dari Tuhan Yang Maha Esa. Pembacaan doa akan dipimpin oleh Bapak Yudi Ardianto. Kepada Bapak kami persilakan.
Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera bagi kita semua. Hadirin yang berbahagia, marilah kita berdoa dengan khusyuk dan ikhlas menurut agama masing-masing. Izinkan saya akan membantunya secara Islam. Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin. Hamdan syakirin, hamdan naimin, hamdan yuafi ni'matahu wa yukafi'u mazidah. Ya Rabbana lakal hamdu kama yanbaghi li jalali wajhika wa azimi sultanik. Allahumma sholli wa sallim ala sayyidina Muhammadin wa ala alihi wa ashabihi ajmain. Allahumma ya Allah ya Rahman ya Rahim. Tiada kata dan rasa yang pantas kami haturkan kepadamu pada pagi hari ini selain puji syukur kami kepadamu atas seluruh nikmat dan hidayah yang telah Engkau anugerahkan kepada kami, sehingga kami dapat hadir bersama untuk mengikuti webinar series Tenaga Kesehatan tahun 2022. Untuk itu, ya Allah, ya Rahman, ya Rahim, jadikanlah acara kami sebagai acara yang Engkau ridhoi, yang membawa barokah, rahmat, taufik, dan hidayah-Mu buat kami semua. Ya Allah, ya Qawi, ya Aziz, kuatkanlah kami Jadikanlah kegiatan ini sebagai penyegar, pembangkit, dan penggugah semangat kami dalam meningkatkan kualitas tugas kewajiban kami, sehingga kami bisa bekerja secara profesional dan proporsional dengan baik dan tekun sebagai bukti syukur kami dan penghambaan kami kepadamu. Ya Allah ya Somad, kami memohon kepadamu, lindungilah kami dari wabah penyakit yang saat ini melanda negeri kami, dan jauhkanlah kami dari bahaya penyakit, dan selamatkanlah kami dari segala wabah penyakit yang berbahaya dan segala bala berkat sifat kelembutan-Mu. Sesungguhnya Engkau Maha Kuasa atas segala sesuatu, sehatkanlah, kuatkanlah, dan tabahkan kami dalam menghadapinya. Allahumma ya Allah ya Ghafar, dengan sifat afuun ghafur-Mu, ampunilah dosa dan kesalahan kami, dosa dan kesalahan ibu kami, dosa kesalahan para pahlawan kami, serta dosa dan kesalahan para pemimpin kami. Ya Allah, ya Sami, ya Mujib, akhirnya kami hanya bisa berharap bahwa Engkaulah satu-satunya zat yang maha mendengar setiap keluh kesah kami, dan hanya Engkaulah zat yang mengabulkan setiap permohonan kami. Ya Allah, perkenankanlah doa kami. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Wa sallallahu ala sayyidina Muhammadin wa ala alihi wa sahbihi ajmain. Subhana rabbika rabbil izzati amma yasifun wa salamun ala mursalin walhamdulillahi rabbil alamin.
Terima kasih Bapak Yudi. Selanjutnya Bapak Ibu, sebelum mengikuti pemaparan materi dari narasumber, kita akan terlebih dahulu istirahat selama 15 menit, dan kemudian Bapak Ibu silakan mengikuti kegiatan webinar di masing-masing OP, baik Persagi maupun PATELKI. Untuk teknisnya, Zoom meeting pagi ini akan kita akhiri terlebih dahulu, dan silakan Bapak Ibu bergabung kembali melalui link yang sudah diinfokan oleh panitia dan juga masing-masing OP. Terima kasih, cukup sampai di sini saya memandu sesi pagi webinar hari ini. Untuk acara selanjutnya, saya akan serahkan kepada OP Persagi dan juga PATELKI. Terima kasih Bapak Ibu dan selamat mengikuti webinar hari ini. Wassalamualaikum warahmatullahi wabarakatuh. Salam sehat dan salam sejahtera untuk kita semua. Izin Bapak Ibu untuk anggota OP PATELKI, silakan untuk mengikuti kegiatan webinar di link Zoom yang sudah diinfokan oleh panitia, dan silakan untuk live pada room Zoom meeting sesi pagi ini. Sekali lagi untuk anggota OP PATELKI, silakan live di link Zoom hari ini dan kemudian lanjut bergabung pada link Zoom yang sudah diinfokan oleh panitia maupun oleh OP PATELKI. Terima kasih. Bapak Ibu anggota PATELKI, untuk link Zoom sudah tertera di layar dan juga sudah kami kirimkan melalui room chat pada Zoom meeting hari ini. Silakan buat Bapak Ibu OP PATELKI bergabung melalui link chat link yang sudah kami kirim melalui room chat. Terima kasih. Izin kepada Bapak Ibu anggota PATELKI yang ada di room Zoom ini, silakan join pada link Zoom webinar yang tertera di layar untuk mengikuti rangkaian webinar OP PATELKI karena room Zoom ini akan digunakan untuk rangkaian acara webinar dari OP PERSAGI. Terima kasih.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Best wishes to all of us. First of all, let's say thanks to Allah Subhanahu wa Ta'ala who has been giving us guidance, happiness, healthy, and mercy so we can attend and participate in this event without any disruption. Praise and salutation upon our Prophet Muhammad Sallallahu Alaihi Wasallam, the best figure of this universe. In this beautiful moment, I would like to welcome Mrs. Pritasari SKM MSc as Vice Secretary General of Indonesian Nutrition Association. The honorable of the speakers at our event, Mrs. Professor Dr. Winnie Chi Siuswi, PhD from International Medical University, Mr. Dr. Zulfitri Azwan Matdaud, PhD RDN, Associate Professor, University of Putra Malaysia, Mr. Yudi Adrianto, SGZ, SA MKM IVO from Indonesian Nutrition Association. And there is also an amazing moderator at our event, Ms. Nurul Asma Ahmad Tarmizi, the Scaling Up Nutrition Program Assistant at National Development Planning Agency. Last, to all participants of this webinar today. I also would like to thank the Indonesian Health Workers Council who has supported the continuity of this event. Welcome to the International Webinar with the theme of Dietetic Update on Chronic Kidney Disease. This webinar is a collaboration between the Indonesian Health Workers Council with the Indonesian Nutrition Association. There will be amazing speakers that will present interesting material about updated information about nutritional care in patients with chronic kidney disease that deserve to be discussed. I hope that all participants will attending this webinar until it finishes. Let me introduce myself. My name is Desi Andes Brenta Sadikin as the Master of Ceremony on today's webinar. Before we continue to the next session, please read today's webinar rule that will be sent by the committee member in chat room. Now, let's hear the event report from Mrs. Pritasari, SKM MSc. For Mrs. Pritasari, SKM MSc, the time and screen are yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning and may peace be upon us all. Our distinguished His Excellency Ministry of Health, Director General of Health Workforce, Chairman of Indonesian Health Workforce Council, Chairwoman of Indonesian Nutritionist Association, speakers, moderators, organizing committees, colleges, and participants. Ladies and gentlemen, first of all, in the name of Allah, the merciful, the compassionate, and praise be to God, prayers and peace be upon our Master Muhammad Sallallahu Alaihi Wasallam and all of his families and companions. On behalf of the committee of the International Webinar on Chronic Kidney Disease with the theme of Dietetic Update on Chronic Kidney Disease, please allow me to deliver the report as follows. First, International Webinar on Chronic Kidney Diseases is organized by the Indonesian Nutritionist Association, supported by the Ministry of Health, Republic of Indonesia. The international speaker is Professor Dr. Winnie Chi Siuswi, PhD,
International Medical University Kuala Lumpur, Malaysia, Secretary General of the International Confederation of Dietitians. Dr. Zulkifli Arwan Mat Daud, Associate Professor from University of Putra, Malaysia. And Mr. Yudi Adianto, SGZ NKN, Dietitian from Dr. Cipto Mangunkusumo Hospital, Jakarta. The participants are the nutritionists and dietitians from the hospital, health center, university, health polytechnic, and other institutions around Indonesia. More than 800 participants registered. Some participants from neighboring countries. The success of today's event is because of the full support from the Health Workforce Council Indonesia, Indonesian Nutritionist Association, and Organizing Committee. Hence, on behalf of the Organizing Committee, please allow me to say thank you very much for your valuable support and guidance. Ladies and gentlemen, finally, please enjoy participating in today's international webinar until the end of the session. Together, we can build a better and stronger collaboration on proper diet management against chronic kidney disease. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Mrs. Thank you, Mrs. Prita Sari SKM MSc for the event report. After hearing an event report from Mrs. Prita Sari SKM MSc, it's an honor for me to introduce our next guest of honor to give a welcome speech. For President of Indonesian Nutrition Association, Mrs. Rudatin SSTMK SKM MSc, time and screen are yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning. May peace be upon us all. Distinguished Mrs. Professor Dr. Winnie T. Siu Swi, PhD from International Medical University. Mr. Dr. Zulkifli Arwan Mat Daud, PhD, RDM, from University of Putra, Malaysia. Mr. Yudi Adianto, SGZ, SA, MKM IFO, from Indonesian Nutrition Association. Moderator, organizing committees, colleagues, and participants. Ladies and gentlemen, first of all, in the name of Allah, the merciful, the compassionate, and praise be to God. Prayers and peace be upon our Master, Muhammad, and on all his families and companions. Ladies and gentlemen, chronic kidney disease is currently one of the chronic diseases that become a health problem in Indonesia. Risk-based data show the prevalence of chronic kidney disease in Indonesia increased from 0.2% in 2015 to 0.38% in 2018. Patients with end-stage chronic kidney disease must undergo kidney replacement therapy to support physiological function through hemodialysis. Diet management in patients with chronic kidney disease is important in preventing the occurrence of malnutrition in patients because they are in the group that is at risk of becoming malnourished. The high prevalence and risk of malnutrition in kidney disease can aggravate the patient condition, prolong treatment time, and increase mortality. Appropriate nutritional care or medical nutrition therapy focuses on the process of nutrition care in dealing with nutritional problems in kidney patients must be done safely, effectively, and qualified to improve the nutritional status of patient, reduce morbidity and mortality, and improve the quality of life of patient. Therefore, we, Indonesian Nutrition Association, are organizing this international seminar program to increase the latest knowledge about international care in patients with chronic kidney disease for all nutritionists and dietitians. We hope participants will be able to gain updated knowledge about the role of nutritionists and dietitians in the treatment and case management of patients with chronic kidney disease, updated assessment and monitoring and evaluation method, medical nutrition therapy, and learning from the case management in promotive and curative approach. Ladies and gentlemen, it gives me immense pleasure in welcoming all of you to this international seminar. We have invited the best experts to discuss updated information and increase the latest knowledge about nutritional care in patients with chronic kidney disease. I hope this international seminar can bring significant benefit and good impact on the treatment of patients with chronic kidney disease. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Mrs. Rudatin NST SKM MSE for the welcome speech. Now it's time to get into the main session. To shorten the time, I will read the moderator's CV today. Ms. Nurul Asma Ahmad Tarmizi was graduated from Food Science and Human Nutrition, University of Florida. She has been working at the Ministry of National Development Planning since 2020 and currently holds the responsibility as the Scaling Up Nutrition or the SUN Program Assistant in Indonesia. Now, please welcome Ms. Nurul Asma Ahmad Tarmizi as the moderator of this webinar to take over the event.
Hello, everybody. Is my voice clear? Thank you.
Yes, Ms. Nurul.
Good morning, everyone. I see that we have participants from all over Indonesia. We have members from Prabu Muli, Sumatera Selatan. We have some from Tanah Toraja, Sulawesi Selatan. So this is an exciting gathering that we have today on the international webinar. So today's international webinar about dietetic update on chronic kidney disease. My name is Nurul, and it is an honor for me to be here. In the past few years, we know that chronic kidney disease has become an increasingly concerning in Indonesia. We know that patients with chronic kidney disease are at a higher risk of developing malnutrition, even more so if the patient is undergoing hemodialysis, right? Which in turn would make the patient's condition worse, leading to an increased morbidity and mortality. So now, as the medical team, especially dietitians and nutritionists, we have the responsibility to prevent the patients with chronic kidney disease becoming malnourished, right? So in order to do that, we will learn how from the 3 speakers from 3 different institutions. I'm going to introduce about them briefly. First, we have Professor Dr. Winnie Chi from the International Medical University in Malaysia. Next, we have Dr. Zulfitri from the University Putra Malaysia. And then last but not the least, we will hear from Pak Yudi Adrianto, who is an experienced nutritionist at the Dr. Cipto Mangunkusumo Hospital in Jakarta. Before we move on, I would like to remind you that as you listen to the 3 speakers, you might have questions. So please feel free to write in the chat box on your right-hand side using the following format: name, underscore, institution that you represent, underscore, name of the speaker, and then underscore the questions that you'd like to ask. Now, time is exactly 10 a.m. We are going to start with our first speaker, Professor Dr. Winnie Chi. Before I start, actually, if I speak too fast or if the speaker speaks too fast, we know that we are fluent in Bahasa, right? So if you have questions or it's not clear, please write in the chat box so that we can adjust ourselves. Thank you. So I'm going to introduce Professor Winnie again. She is the current president of the Malaysian Dietitians Association and a key member of several working committees on clinical practice and nutrition guidelines in Malaysia. She has produced several education materials for kidney patients and active in conducting research on diabetes, obesity, bone health, and chronic kidney disease, which the topic that we're going to talk about today. Now, without further ado, please welcome Professor Dr. Winnie Chi. Time is yours.
Hello and good morning to everyone. First of all, I'd like to thank PERSAGI for the very kind introduction to speak to all of you at this international webinar. And my role today is to talk to you about the roles of dietitian in CKD management. In the next 30 minutes or so, I will be sharing with you, and I hope that you'll be able to gain an understanding on the nutritional problems that are being faced by CKD patients and how the role of the dietitians can be executed in order for us to carry out the nutrition care process for these patients, and finally end with some take-home messages. Now, I think as dietitians, we all know that every day in our day-to-day clinical practice, we do come across some high-risk CKD populations that we counsel on a day-to-day basis. And in Malaysia, at least, diabetes and hypertension are the leading cause of CKD. And I'm sure it's also the same in Indonesia. And whenever we counsel diabetes and high blood pressure patients, we do also often get them in stages of kidney failure. And that is where then our actually dietary consultation becomes very important to help them to either delay their progress of CKD, or if they need to have more intensive counseling due to their comorbidities that predisposes them to a high risk of CKD. Now, if we look into the nutritional problems in CKD, I think dietitians who work with CKD patients are always cognizant of the fact that these patients have a high risk of protein energy wasting. This is actually a very nice diagram that's being taken from the publication from the International Society on Renal and Nutrition and Metabolism, of which they then came up with a consensus about protein energy wasting in CKD patients. As you can see here from this diagram that CKD actually has a lot of predisposing factors that can lead to malnutrition. And this include uremia, There are comorbid conditions of having diabetes or cardiovascular disease, and also depression that also affects their dietary intake. There are also, if they are on dialysis, then there are dialysis-associated catabolism, and a lot of metabolic derangements happen during chronic kidney disease and uremia, such as metabolic acidosis, for example. That also affects, predisposes our patients to protein energy wasting. Of course, then these risk factors also leads to poor dietary intake, and that itself is another cause of protein energy wasting. The presence of inflammation is also another reason why catabolism increases in such patients, and the consequences of PEW or protein energy wasting is actually high, such as infections. It leads to early cardiovascular disease, frailty, and depression in our patients. So we can see that there's a multifactorial reasons why the dietitian then plays an important role, because the patients have a lot of nutritional problems when they have CKD. Now, nutrition goals for renal disease management, I'm sure Dr. Zul will be able to, dwell further in this talk after me. But we all know that the common goal here is basically to look at how these goals are actually applicable for the different stages of chronic kidney disease and if the patients are on dialysis. One of the main roles of dietitians is to ensure that our patients with CKD attain and maintain an optimal nutrition status. And this includes, a general healthy nutrition, whereby there's a balanced diet of all the essential nutrients and food groups that's required, and this needs to be tailored according to the stages of CKD. Another important point is also to monitor weight, because weight is to prevent malnutrition and any undesirable loss of body weight. If our patients present with uremia and symptoms of uremia, then we will also need to, have the right dietary advice in order to help them overcome things like nausea, vomiting, the loss of appetite, the feeling of fatigue, as well as lethargy. Now, there are also other specific goals that as dietitians we need to apply, and this again depend on the sign and symptoms of our patients, the comorbidities, and the stage of kidney failure, how advanced it is, and if they are already on dialysis. So I think many of us who work in the area of renal nutrition would know that we have to look into things like maintaining fluid and electrolyte balance, sodium and potassium, the control of phosphate. If they have comorbidities such as diabetes, then optimal glycemic control is very important, especially if they are in the mid stages of CKD, like stage 3, 3B, moving to stage 4. This is where optimal glycemic control then will help to delay the progression of kidney disease. And also similarly with the control of other comorbidities such as hypertension and their lipid abnormalities, and not to forget also that it's important to look into exercise and physical activity. So who are the patients who are being referred to dietitians? So most of the case referrals come from outpatient as well as inpatient, and we receive these referrals to initiate dietary intervention, very commonly first for CKD stage 3B to 5, including patients who are non-dialyzed patients who wish to go on conservative management in order to delay their progression to dialysis. When patients present with complications that are associated with the kidney failure, such as sodium and fluid management, electrolytes imbalance, malnutrition, these cases need to be referred to dietitian. And of course, I think all dialysis patients will have to be referred to dietitian to assess for malnutrition, and as well as other metabolic disorders and complications that come with dialysis. So these are some very specific common reasons that I've mentioned before. We often get cases referred to us for volume overload, for malnutrition, although that may not often be the case, but it usually malnutrition as well as with other comorbidities. It could be weight loss, it could be poor appetite, it could be hyper or hypokalemia, hyperphosphatemia, hyperlipidemia, for symptoms control, taste aversion, for nausea, often leading to uncontrolled weight loss, and then food texture, like if they have any swallowing problems, and also being referred for diabetes. So these are all the different types of cases that we can pick up that have got chronic kidney disease, that the role of the dietitians become very important. Now let's dwell a little bit further then. When we get referrals for these patients, what does the dietitian do? So as we know, dietitians, our scope of practice is to provide medical nutrition therapy using standardized nutrition care process. I'm sure in Indonesia as well, when patients are being referred to you, we follow the ADIME, which is first gathering the evidence, which is assess the patients for nutritional risk. And then once we know what the nutritional problem is, we will formulate a nutrition diagnosis together with the root cause and as well as what are the monitoring that we need to do. And then from there, we will move on to formulating the interventions that's tailored and patient-centered, and a discussion being held with the patient on what he or she can do in order to resolve the nutritional problem. And finally, we always need to monitor and evaluate our patient's progress. And then the cycle goes round again when we see the patient the next time to see if the nutritional problem have been resolved or the new nutritional problem has actually arisen. So in this process, I shall be going through this nutrition care process is because essentially the role of the dietitian centers around the nutrition care process. I'd like to point out to you that recently the Kidney Disease Outcomes Quality Initiative from the NKF in the United States and the Academy of Nutrition and Dietetics have come up with some the latest clinical guidelines for nutrition for CKD, and you may want to refer to this in order to know more about some of the roles that we need to do as dietitians. Let me now first go into screening, which is an important process because what essentially we're screening for is risk of malnutrition. So for adults with CKD stage 3 to 5 on dialysis or otherwise, it is reasonable to consider that there should be a routine nutrition screening done, at least biannually, right? And the intent is to identify those who are at risk of protein energy wasting. So this is actually coming from this KDOKI Nutrition CKD Guideline Working Group that essentially we should be coming in early to screen for malnutrition in these patients. Now, we all know that the uremia leads to the malnutrition. I don't think I will go into more details here, but it is quite clear that uremia leads to muscle and fat loss, as well as the inflammations and also the metabolic acidosis. All this breaks down the protein in the body, and this also leads to malnutrition. When does this malnutrition occur? Most of the time, the deterioration of the nutritional status will begin from stage 4 CKD onwards. And once we have patients who are stage 4, I would normally, screen for protein energy wasting or any signs and symptom or risk of malnutrition. And we will probably need to, take good care of this because as the MNT would say, there's usually a need to slow down that progression. So you may be reducing protein intake, but at the same time ensuring that malnutrition does not occur, because in case the patients go on to dialysis, then they will have a very high risk of having protein energy wasting. So protein energy wasting, as we know, one way for us to screen the patients is to follow the criteria and the nomenclature that's already been, put out there by the ISNRM group. One is to look at the biochemical criteria, looking at serum albumin levels or pre-albumin levels. Most of the time, we do not get pre-albumin levels, but we do get serum albumin levels. Sometimes very low cholesterol level can also indicate malnutrition. The other criteria is body mass index for BMI less than 23, or there's been unintentional weight loss of more than 5% in the past 3 months, or more than 10% in 6 months, and a body fat that is less than 10% of the body mass. So I find that using the BMI and the weight loss is something very that we can do in case we do not have any particular, sophisticated machine to measure body fat. The other way is to look at muscle mass, which is another criteria, and we can use the muscle mass loss if there is significant weight loss of more than 5% or 10% between 3 to 6 months. And we can also look into muscle area of the arms, so you can measure the mid-arm muscle circumference or tricep skin fold in order to check whether there's muscle mass loss or not. And the other domain is the dietary intake. Dietary intake can be looking at from our diet history, whether the protein intake has been too low, less than 0.8 if in dialysis, or lower than 0.6 recommended for stages 3 to 5 of CKD if they are not on dialysis. and also how much energy that they consume, and if they consume less than 25 kilocal per day for at least 2 months, then they are at risk of protein energy wasting. So according to ISRNM, it's necessary to fulfill at least one criteria in 3 of the 4 categories proposed. So either biochemical, body mass, muscle mass, or the dietary intake criteria. So this is a way for us to screen for protein energy wasting. Recently, my colleague and I, we have in Malaysia, we've published looking into the prevalence of protein energy wasting, and this is among dialysis patients, and you can see that the prevalence of PW is actually quite high, more than 50% to almost 80% in peritoneal dialysis patient in this small sample size that we see here. But the point here is that we do have to look up for PW, and the role of dietitian here is to actually screen for it whenever we see CKD patients. So the next thing, of course, once the patient is identified as having malnutrition or any other comorbidities or complications that require referral to the dietitian that I mentioned earlier, then the dietitian goes into the actual proper nutrition assessment. So when we're doing the nutrition assessment, essentially what we will need to cover is, of course, getting to know the patient in terms of the client history. So it is the role of the dietitian to do a medical and health history that we can assess the presence of comorbidities and anything else that can affect the progression of CKD. So what's important here, normally age, gender, and marital status do play a role, as we know, because whether the patient is able to eat enough and have enough provision of nutrition at home. Their ethnicity, education, and background will affect how much of information that we can impart to them and at what level. Their socioeconomic background, of course, will have an impact on their food accessibility as well as their food availability. And things like medical history, which can exacerbate the malnutrition if the risk is there. I find that quite a few patients in Malaysia also will seek alternative therapy, and they may be taking herbal medications, and this sometimes may contraindicate in terms of their nutrition status. I have counseled a patient before who actually sought alternative therapy and end up very malnourished because the wrong sort of advice was given to the patient on what kind of food that needs to be avoided and so on, and that actually led to a higher risk of malnutrition. So I think these factors are all we know as dietitian is to help us to tailor our diet counseling and our education to our patients, and we do that better if we have a good understanding of the client history. Now, of course, we will also do the anthropometric measurements, and essentially what we're looking here is using our clinical judgment to look at, serial measurements. So looking at the actual measured weight, if you're dealing with patients with dialysis, then you want to look into post-dialysis weight. The history of weight changes is important. So acute versus long-term weight changes. And I always look into, the past 3 months, what has been happening in terms of the anthropometric changes, because changes can occur due to fluid status, the stages of kidney function, the body composition of the patients also may differ, and also to assess whether there's edema or any fluid accumulation or not, for us to be able to assess the body weight properly. In order for us to determine the BMI as well as the whether there's any significant muscle or fat loss. So if your clinic has got the luxury of having some of this sophisticated equipment in order for us to measure body composition, I think that would be really very useful. Otherwise, you can also use tools like that can, simpler tools that can measure tricep skin fold or even your tape in order to look into mid-arm muscle circumference, and using the correct reference standard in order for us to assess whether there has been significant muscle or fat loss in our patients. Biochemically, I suppose it's important to integrate that data, and we should be looking at changes over time as well. And this is to help us to determine eventually whether there's been any physiological changes in the patient. Glycemic control is important. To see how well the patient has been controlling, especially in the early stages of CKD, because the objective there would be to want to delay that progression of CKD. And we know that with better glycemic control, if the patient has diabetes, better blood pressure control, all this helps to delay that progression, and diet, of course, plays an important role there. Monitoring of inflammation, the kidney function, to look also whether how is the calcium, phosphorus, and parathyroid hormone levels. Does the patient start to exhibit sign and symptom of anemia, dyslipidemia, and any other electrolyte disorders? So the biochemical data can actually help us understand better the disease-related changes that occur in these patients. I find nutrition-focused physical examination a very important skill that dietitians can have, where we are looking for physical signs of malnutrition. And looking into the mouth, again, is very important. So in elderly patients with CKD, I often also check and see whether are they using any, false. Are they able to, chew their food well? I also look into the mouth, see if there's any, signs of physical signs of lesions and all that may affect the swallowing and chewing problems. GI symptoms, whether patients is experiencing nausea or vomiting, because they could be having uremia, depending on the stage of kidney failure, especially for the later stage, or patients is actually experiencing constipation or diarrhea. I also look into the muscle loss and fat loss, because this, if I do not have a body composition machine, actually looking at it physically through muscle and fat loss, it's a very useful way for me to know how much of muscle loss is present already. And we can also look for signs of fluid retention, edema. Hand grip strength is another important factor that also looks at muscle strength, and in itself is also an indication of nutrition status. So these are some photographs of patients that I've done, some of the patients that we have looked at, and this is as part of our screening tool of using SGA. It's also part of nutrition-focused physical examination. You could be looking at, this is actually a CKD patient, and you can see here for this gentleman here, there is significant muscle loss, as you can see here very clearly from the interosseous muscle, the knee, the calf, the quadriceps, the shoulders, and the scapula is very prominent, and also there seems to be some amount of fat loss here as well through the triceps and bicep skin fold. So this sort of examination actually helps us get a better picture about the nutrition status of the patients. You can use the SGA. It is recommended that the use of the SGA is a valid and reliable tool for us to assess nutrition status in our patients. The 7-point SGA can be used, and which looks at dietary intake, GI symptoms, functional status, the disease state, the comorbidities, as well as the physical examination of the foot, like the photographs I showed you just now. I find the SGA a very useful tool, especially it gives me a holistic view on the nutrition status of patients. There are other very specific tools for assessment of patients. The DMS, or the Dialysis Malnutrition Score, is available. It's very similar to the SGA, consists of medical history as well as physical examination, or more specifically is the Malnutrition Inflammation Score. This one looks at, it's recommended for dialysis patients, for example, where you also look at medical history, but there's also a component on body mass index, and it requires some laboratory parameters taking into account serum albumin and TIPC values as well. So we actually did a study to compare whether these tools are better or not compared to the SGA, and we find that both these tools are actually valid tools for nutrition screening, and this is for amongst dialysis patients in Malaysia. And the DMS is more practical or simpler tool because it doesn't require the laboratory markers, so it's much easier for us to use. So besides already looking at the client history, the anthropometry, and the biochemical, as well as screening for malnutrition using SGA, the other important component, of course, is the dietary intake. And as dietitians, it is our role to look into the food nutrition related history. I think this is the most important, and this is probably the core competency as a dietitian. We actually would look into the diet history and records, right? Nowadays, if you have smartphones, some of my patients have smartphones, they can take a picture of what they eat and then send it to me, so I can sort of validate for them whether they are making, to know better what they are eating. So it's very important for us to assess their intake of micronutrients and macronutrients, of course pertaining to nutrients which are significant for CKD. Medications and over-the-counter drugs are also important, because if there's fluid restriction, sometimes that also, they need to drink more water because they want to take more medication. So that has an impact as well. The intake of dietary supplements, and also more importantly, if they are taking any other herbal or botanical supplements, and whether there's going to be any drug-nutrient interactions there. One of the key factors that we also look into is actually the readiness to change for our patients, especially those who have early CKD. It is very important for them to go back to controlling back their diets and their lifestyle to slow down that progression of CKD, and they need to control their diabetes, control their high blood pressure, dyslipidemia, lose some weight. All of these are lifestyle related, and sometimes when the patient's readiness to change is not there, it is quite challenging for us to assist that patient to make those changes. So I often also talk to my patient a lot about the reasons for the change, so that we know whether are they ready for change or they're still thinking about it. Then we can approach the right dietary counseling method for them. It's also important for patients, especially those in low income group, to access, to look into the access to food. I find that when I work with dialysis patients especially, because most of them tend to be from lower socioeconomic groups, especially those kind of patients, their access to food is limited. There's also the income status, and they often eat the same type of food every time, and therefore managing the sodium, potassium and phosphate can be quite challenging. So it's important that we do a thorough diet history when we are looking into assessing our patients. So it is recommended that you can use a diet recall 3 to 7 days or food frequency questionnaire in order to look into these nutrients which are important for assessing their nutrient intake for CKD. After you have done a nutrition assessment, and if you do it well, you should be able to formulate the nutritional problem. And in this case, of course, in Malaysia, at least all of us practice the writing of the nutrition diagnosis. So the nutrition diagnosis is actually a very critical link between nutrition assessment and deciding what is the nutrition intervention that we need to do, right? And so, for example, we will write it in the form of the standardized language of writing down the problem, the etiology, and the sign and symptom. So the nutrition assessment will help us formulate this nutrition diagnosis, and then the etiology is where we focus our intervention on, and the sign and symptoms tell us what to monitor. So take, for example, excessive protein intake, which may be present in patients who maybe have advanced CKD. And this could be because they have limited knowledge about protein foods and how much to eat for their kidney function. And how do you know that excessive protein intake? From our assessment, we could put that maybe it's the diet recall that shows that the intake is actually higher than the recommendation. So very often we try to focus on the intake domain because it's something that dietitians can immediately within our control to help our patients to change. But sometimes it can be about food nutrition knowledge deficit, or they have limited knowledge. Sometimes it's readiness to change. So we really need to do a thorough and good nutrition assessment, looking into the various domains for us to identify what exactly is the nutrition problem in our patients. So as I mentioned just now, at least in Malaysia, all our dietitians practice this standardized language from the AND. We have access to the NCPT, and we would then choose the right nutritional problem that is appropriate for our patients. Some of the common nutritional problems in patients with CKD and perhaps, sorry, this is an error here, I mean CKD with diabetes, will be, it could be inadequate energy intake, protein intake, it could be about their mineral intake, sodium, potassium, phosphate, for example. Fluid intake is also can be a problem, or they have either inadequate mineral or excessive mineral intake, or there's impaired nutrient utilization with uremia. It can also be about malnutrition, of course, or there's any altered lab values like rising urea or creatinine because of the uremic conditions. Often it can also be about the behavioral of our patients, like not being ready for diet change or having undesirable food choices, or they don't know how to monitor themselves, or they have physical inactivity. So all of these are are the common nutrition diagnoses that I come across with patients with diabetes and with CKD. So the treatment intervention for patients with CKD, that is also another role of the dietitian, of course. And there are very few things that you can consider. One is, of course, the nutrition prescription. How much exactly are the calories, protein, and other minerals that we're going to prescribe for our patients, including the fluid. Then the food nutrient delivery. How are we going to deliver that? What kind of education are we going to give the patient? And do we need to incorporate aspects of counseling as well? So I'm sure Dr. Zul will be talking after me. We'll be covering some of the MNT recommendations for you. And therefore, I will just briefly show this. So this is all in a nutshell, what we need to do for the various stages of CKD as well as for patients with dialysis. I find the renal exchange list might be also useful for us, especially for meal planning for our patients. So this is something that we probably will develop for our own countries in order for us to monitor and meal plan for the patient's diet. For intervention, usually the individualized approach could be, of course, the meal planning and suggesting what are the meals and snacks that patients can eat. There may be indication for us to consider enteral nutrition or parenteral nutrition, as well as any other, nutrition supplements such as maybe vitamin supplements like iron tablets, for example, if patients have anemia. And so these are some of the key areas that we talk about when we talk about food and nutrient delivery. Now, of course, in patients with albumin, just like to point out that sometimes nutrition alone may not improve the hypoalbuminemia, because very often low albumin is also related to inflammation. And we can look at whether the C-reactive protein is high rather than just the poor nutrition status. Yeah? So if you have patients have low albumin levels, sometimes we have to consider other aspects such as inflammation, the metabolic acidosis, right? Of course, as dietitian, our role is to ensure that we still provide adequate protein and calories for the poor nutrition status. The role of nutrition support is also there. The first line action is, of course, we have to ensure that we counsel on the optimal dietary intake for food and beverages, consider things as oral nutrition supplementation, and if all of that is still not meeting requirement, then very severely malnourished patients will require enteral nutrition support. So these are some of the renal related ONS support that you may have in your various country, and you look into energy density, protein content, carbohydrates, the fat blend, the fluid content, of course, because most of these patients require fluid restriction, and these products need to be of low potassium, phosphorus, sodium. The macronutrients should suit CKD patients, and anything else that we think may be beneficial for renal patients. Now, education plays a very important role. So as dietitians, we also need to impart nutrition knowledge to our CKD patients. This is, to ensure that we help them to manage and modify their food, and we have to give recommendations and educate them. Especially, I find that I often need to educate about protein intake, especially for those who are not on dialysis and wanting to slow down progression of their renal failure, and ensuring also that they know what kind of proteins to choose and how much to eat. So this is part of the education that we can impart on our patients. Fluid restriction is also important, and very often we would give out list of foods that contain potassium content of fruits and vegetables that they can choose, and phosphate content of the food, so that they know what kind of food choices they need to make in order to control their high phosphatemia or high potassium levels and so on due to the CKD. Counseling becomes important for CKD patients, because very often when patients get very fearful and worried when they find out that they have CKD, and they are very concerned about how do they then manage what is happening to them. So nutrition counseling plays an important role, and as a dietitian, we need to be supportive, and it's a collaborative process as well, where we can discuss with our patients how to prioritize the goal. CKD patients often have a lot of different things, different aspects of their diet that they need to control. The fluid is a big challenge, especially in our country where it's a hot weather. Cutting down their protein intake is also a challenge. At the same time, they need to manage their diabetes. At the same time, they also have to look at sodium. So you can imagine that all of this is a bit overwhelming for our patients. So it is important to use our counseling skill to establish, the goals and individualize the action plans for them, right? So we can use a lot of, some of the theories in order to support our patients. Either you use motivational interviewing, cognitive, CBT, behavioral therapy, the health belief model. All of that is important to help our patients be able to manage their diet and their lifestyle to meet their goal of either delaying the CKD. If they're already on dialysis, then again, it's also very important that most of my patients are quite depressed when they are on dialysis. So our nutrition counseling skills becomes very important for us to motivate them to still, have a reason to why they should still comply to their diet, for example. So the last part will be the monitoring and evaluation. Of course, once you have given your nutrition intervention, the role of the dietitian is to monitor, to assess how effective we have been with our nutrition intervention, and to identify if there's still any nutritional problems that have yet to resolve. So that is actually also sets the state for the next counseling session with our patients. Another important point I'd like to make here, that as a renal dietitian, it's very important that we coordinate care. So we work very closely with the nephrology or the attending physician on the patient. We work very closely sometimes with diabetes educators because they may also be having to manage their diabetes to slow down progression of kidney disease. We work well with other healthcare professionals. The psychologists also play a very important role. So as a dietitian, we don't work alone, but it's important that we coordinate our nutrition care with other healthcare providers that's as relevant and needed in an interdisciplinary team with our patients. So I guess this comes to the end of my talk. I hope I've given you some information on how clinical dietitians work with CKD patients, the core responsibility being to perform that nutrition care process. So we need to screen and identify for malnutrition. We need to assess our patients to identify nutrition diagnosis and the etiologies for it, translating evidence-based MNT into practical advice for our patient, support our patients' dietary change through education and counseling, and monitor and evaluate our patients' progress for the dietary intervention, and identify any new nutritional problems may arise, or is the nutrition problem resolved. And I think it's very important that we also collaborate interprofessionally when we work as a dietitian in managing chronic kidney disease. And with that, I'd like to thank you very much for your attention.
Thank you so much, Professor Winnie, for the presentation. From her talk, she highlighted the nutrition care process from the nutrition assessment, including anthropometric assessment using PEW, biochemical test, and then we have nutrition-focused physical exam, food history using that recall, nutrition diagnosis, nutrition intervention, and even nutrition education. And then she, at the end, highlighted the importance of collaboration with other health professionals. So it's not just us dietitians, but also doctors, nurses, and others. So mungkin saya sedikit dalam bahasa. Jadi dari presentasi Profesor Winnie tadi, kita lihat beliau menekankan proses asuhan gizi untuk pasien dengan penyakit ginjal kronis. Nah, pentingnya seorang dietitian melakukan asuhan gizi yang tepat pada pasien CKD, khususnya pada kondisi khusus yang membutuhkan perhatian, misalnya malnutrisi, untuk meningkatkan kualitas hidup pasien dengan CKD. Pemberian intervensi yang disebutkan oleh Profesor Winnie itu secara personal, jadi tidak secara umum, tapi pada kasus-kasus tertentu perlu pendekatan-pendekatan perubahan perilaku yang bisa membantu pasien itu lebih patuh terhadap diet yang sudah dibuat oleh Bapak Ibu sekalian sebagai ahli gizi. Kemudian sebagai ahli gizi juga kita perlu melakukan monef secara berkala untuk memastikan perkembangan pasien itu bagus dan cocok dengan diet yang sudah dibuat, seperti itu. Kemudian di akhir beliau menekankan peran ahli gizi itu penting, tapi juga perlu melibatkan profesi-profesi lainnya untuk bekerja sama dan membantu kualitas hidup pasien dengan CKD. Baik, we are going to continue with our next speaker, Dr. Zulfitri, who will talk about the latest medical nutrition therapy guidelines for chronic kidney disease patients. Is he here with us? Professor Zulfitri?
I'm here.
Hello.
Hello.
So I'm going to introduce a little bit about you first before you start the talk, if you don't mind.
Yeah, sure.
Thank you. Okay, so Dr. Zulfitri is an associate professor at the University Putra Malaysia, whose research focuses on the multifaceted nutritional intervention for advanced chronic kidney diseases, patients in view of heightened inflammation and increased prevalence of protein energy wasting in this population. Professor Winnie, if you remember, she also mentioned about the protein energy wasting, which is common in CKD patients, right? So just before his talk, he has requested for us as the participants to fill out a survey link posted on the chat box. I think I need help from our colleagues here to post it there. Thank you. And then it should take 1 to 3 minutes, and he will present the results from the survey at the end of his talk. So I think this is going to be interesting. So please do fill out the survey. Check out the link on the chat box on your right-hand side. Dr. Zulfitri, time is yours. Thank you.
Thank you very much to the chair for your kind introduction. And first of all, I would like to thank PERSAGI for inviting me to share with my fellow dietitians in Indonesia pertaining to the sum of updates on medical nutrition therapy for CKD patients. Okay, my name is Zulfitri. You can call me Zul as a short name. Okay. Just before I proceed further, some disclosure that I would like to make. There are some data from my research that I present in this presentation, and they are derived from the research that was funded by the government of Malaysia and also National Kidney Foundation of Malaysia. And I have no other actual or potential conflict of interest in relation to this presentation. As mentioned by the Ms. Chairman just now, you can actually, I would need your favor to fill up some quick survey, and we're gonna look at the result of this survey towards the latter of this presentation. So if you can, pull out your cell phone and scan the QR code, that will be great and very much appreciated. All right. So there are a few references that I use in this presentation, and my primary preference is actually come from KEDOKI guideline in 2020 as presented by Prof. Winnie just now. And I also cross-reference it with, some of the guideline that I believe you as a nutritionist and Indonesia is probably using it. From the PANEFRI guideline, particularly on consensus nutrisi pada penyakit ginjal kronik, and also I cross-check it with our Malaysian guideline as well, but our Malaysian guideline is pretty dated and we are in the process of updating it. However, there are some aspects that I do not or touch in this presentation because obviously we don't have much time, particularly on acute kidney injury. For your information, there are latest guidelines by ASPEN that are published last year, on CKD, AKI with CKD and AKI without CKD. So if you are interested, feel free to look at that particular guideline. This was published by Professor Fiaccadori, my colleague in Parma University in Italy. All right. And also would not be focusing on the pediatric kidney disease as well. Okay, there are, for your information, in the last 5-6 years, in certain association, they have published and update their guideline. The last KDOKI guideline was published in year 2000. So it's really, really, needed for them to publish the latest guideline in 2020. But there are also some guidelines that are being published in ranging from 2019 to 2015 by different countries. But unfortunately, based on Bakalodi et al., if you can look at this paper, she actually reviewed all of these guidelines in terms of their quality, and none of them are actually meeting the quality that we expect, except for KDOKI and also CHARI guideline from Australia. It's just that CHARI guideline is pretty dated already. Okay, let's move on to our main issues that we want to look for in this presentation. So we know that kidney disease is, the main or major public health issues worldwide. In 2017, it has been reported that over 1 million people worldwide die because of CKD. And more importantly, many more people not just die but loss of productivity as a result of getting CKD is much worse. And that's lead to huge economic impact. We know that the prevalence or the incidence rate of end-stage kidney disease varies from one country to another. But if we zoom into Southeast Asian country, typically in Malaysia, in Singapore, in Thailand, in Taiwan, in also Japan, it significantly have a much higher incident rate of ESRD. But how about in Indonesia? So this was the latest data published by Penafri in 2018. So we can see that what alarming here is that there is significant increment trend. In the last 3 years, 2018, 2017, 2016, in terms of patient end up getting ESKD and have to undergo hemodialysis in order to sustain their life. How about Indonesia versus the rest of Southeast Asian country? If you can see here in the, over the years, Indonesia has enjoyed relatively lower ESRD incident rate. However, as reflected by Penafri data in the 2016 particularly, you can see there is a steep increment in terms of the incident rate of ESRD. And if we are continuing with this kind of trend, it is no surprise in the near future you're going to surpass Malaysia and other Southeast Asian countries. So what are the goals? I think Prof. Mini did a very well job just now describing what are the role of dietitian, especially in dealing with CKD patients. So I would like to summarize once again in terms of a goal for MNT for CKD patient. Basically, we want to delay as many people as possible getting end up with ESKD because we don't want them to be on dialysis therapy. The reason being because dialysis therapy is very expensive, right? And then of course, as the patient progressed toward end-stage kidney disease, we know that they started to accumulate uremic toxins, and then they started to experience all sort of complications. And that is one of the role of us to prevent and manage all of these complications. For example, in terms of electrolyte and fluid balance. And of course, we want to maintain optimal nutritional status. That is a very, very important role of us. We know that many of patients, once they are on CKD5D, when they are on dialysis, for example, many of them not really die because of the kidney disease per se, but rather because of the complication associated with chronic kidney disease, such as malnutrition, cardiovascular disease, and so on. So it's rather important for us to maintain a very good optimal nutritional status for them so that they can actually be a productive human being, right? So let's dive into the guideline that we're gonna discuss today, okay? So the guideline by KEDOKI, the targeted population for this guideline is basically those adults with CKD 1 to 5 and those adults undergoing dialysis treatment, be it peritoneal dialysis or hemodialysis. And also, interestingly, in this particular guideline, they also include a post-transplant recipient, a stable one, I mean, after 6 months of transplantation. There's not so much adjustment in terms of immunosuppression and so on and so forth. So altogether, there are 74 recommendations being made, and this recommendation covered a wide range of nutrition care process, from nutrition assessment to nutrition intervention and so on and so forth. And it's also very, very interesting to highlight that out of these 74 recommendations, 80% of it, when we count, is actually opinion-based rather than based on evidence. I'm going to talk about it slightly later. So in terms of the literature that they included in the guideline, it was based on from 1985 to 2016. Bear in mind that although the guideline was published in 2020, but the literature that they included in the guideline was up to 2016 only. And they only included literature with English and published in certain indexing website. So bear in mind that it is sometimes when they say that it is insufficient evidence, it's not necessarily there is no evidence. There are probably evidence out there, some of the literature published in Bahasa Indonesia, for example, and published in your local journal, and these are not being picked up by the guideline. All right, before we proceed further into the specific details of the guideline, it is very important to look at the grading of the evidence that are using in this guideline. They classified the guideline in terms of quality of evidence based on A, B, C, and D. A meaning that they have high confidence level in which it is very unlikely that any new research will change their confidence on that particular aspect. For example, in terms of serum albumin, they have very high confidence level that serum albumin is the predictor of mortality and hospitalization. And this has been reported worldwide, and it's very unlikely that this is going to change, right? And for level D, quality of evidence, they have a very uncertain about the evidence, and of course when we fit in with new evidence, definitely the recommendation will change in the future. And on top of that, they also have 2 levels of recommendation. Level 1, they call it we recommend. And what does it mean for us as clinicians? That we have to make sure that all patients should receive this recommended course of action. And at the institution level, we can actually use this kind of recommendation as part of the quality criterion or key performance index that we should actually achieve that. So which is a good thing. So level 2 is a we suggest. And we have to consider, different options for a patient. It's not necessarily that the patient has to follow that, but it has to be individualized according to the patient's need. All right, altogether, the guideline comprise all 74 recommendations, and most of the recommendations are in terms of the nutrition assessment, and the rest are component of medical nutrition therapy, in which we're going to talk later. And before I proceed further, throughout the guideline, if you have read it, they always mention about metabolically stable patient, because all the guidelines are applicable to that particular population only. So what do we mean by metabolically stable patient? Metabolically stable mean that the patient has no active inflammatory or infectious diseases, not been hospitalized in the last 2 weeks, and there is absence of poorly controlled diabetes, absence of any critical illness such as cancer, and also absence of the significant short-term loss of body weight. So we have to really be, understand what the guidelines are covering and meant for. Okay, so I just would like to summarize some of the guideline on the nutrition assessment in one single slide, because Prof. Winnie already covered much of it. Yeah. So the guideline talk about the usual care, who should be giving the usual care, and when we should actually give the usual care. So the routine nutritional screening should be, conducted biannually. And in terms of providing nutrition assessment or doing the nutrition assessment, that is actually the role of clinical dietitian or nutritionist. And they highlighted that there is limited evidence in terms of the use of nutritional screening tool over the other type of nutrition screening tools. In terms of the device or anthropometric measurements, they recommend to use a multi-frequency BIA whenever available to evaluate the body composition of the patient, and they recommend the use of DEXA as a gold standard. Yeah. However, we have to put this into our context practice. We are not, going in reality, DEXA is not going to be available for most patients in a way. All right. So there are alternative methods that we should actually explore, such as using skin fold thickness in order to evaluate patient body composition. And what interesting is that in this guideline, they clearly highlighted that BMI should not be your primary or sole marker to evaluate your nutrition status of your patient. Instead, research have shown BMI are good predictor of mortality, but it's not sufficient to indicate the protein energy wasting of your patient. How about the laboratory measurements? Again, they are highlighting the use of serum albumin as predictor of mortality as well as hospitalization, but not as a predictor of nutritional marker. So it has to be used in accordance or together with other nutritional parameters. So what are the methods to assess energy requirement? So they recommend to use indirect calorimetry but if we don't have indirect calorimetry, we can use a disease-specific predictive equation that are available or cross-reference in the guideline. And in terms of the composite nutritional indices, the Prof. Winnie just presented just now, we can use 7-point SDA or malnutrition inflammation score to evaluate our patient's nutrition status. And in terms of dietary assessment method, they are recommending to use 3-day food record, but we can also use alternatives such as food frequency questionnaire, multiple 24-hour recall, and so on and so forth. So that's pretty much sum up on all the recommendations pertaining to the nutrition assessment. All right. And before we proceed further, because after this, I believe that you're going to go through case study by Pak Yudi, I believe. So in doing your case study later on, I'm sure that you have to calculate the nutrient requirement of your CKD patients. And in order to do that, you have to be based on certain weight, isn't it? So in this guideline, they highlighted that there are no specific type of weight that you can actually use to calculate the comparative standard or nutrient requirement of your patient, because that should be depends on your clinician judgment. You can use either body weight, usual body weight, current body weight, or adjusted body weight. It's rather, as academic, it's rather difficult when it comes to the clinical judgment, especially if we want to talk this, we want to educate our undergraduate students about it, because they always want a black and white about it. Yeah, they can't really see in terms of clinical judgment. As clinical judgment, you only gain it with more experience. So I previously, when I was in the US practicing, I was always using ideal body weight by Humvee method because it's pretty easy to calculate. You know, every 5 fit women, so the ideal body weight is 100 pounds, and you're going to add additional 5 pounds for every 1 inch increment, right? So it's pretty easy to calculate that. But when I returned back to Malaysia, you know, my dietitian was looking at me, was like, this is not really common thing they are using here. So basically in Malaysia, what we are using is that we determine IBW for kidney patient if their BMI is less than 20. So you're going to calculate the ideal body weight as BMI 20. Vice versa, if their BMI is more than 25, you're going to calculate the ideal body weight as BMI of 25. Otherwise, you're going to use the current body weight of that particular patient. So that is different from one country to another. But I think when I look at the PERSAGI guideline, you pretty much are similar like us. But do bear in mind as well, we have some other techniques as well as, for example, edema-free body weight, and also adjusted body weight, and also desirable body weight. This one, desirable body weight, is based on the nomogram by Professor Koppel, I think. So you can look at that nomogram, but bear in mind the data that derived from this nomogram is actually from the US population. So it's not really, you know, applicable to our population. So I did compare how does the latest KEDUKI guideline compare to the PERSAGI guideline that you dietitians are using in Indonesia. So basically, it is good to see that in PERSAGI guideline, they highlighted the multifactorial pathogenesis of protein energy malnutrition. And back then, they already identified that serum albumin and BMI are predictor of mortality, which is a good thing. But what is missing in PERSAGI guideline is that they miss out to highlight about when the screening and assessment should be conducted, and what are the additional tools on top of MIS, you know, that can actually be used, such as, you know, SGA and PCR and so on and so forth. And other considerations should also be made on in terms of knowledge, belief, attitude, you know, access to the food, depression, cognitive function of your patients, right? So in terms of moving on to the next one is in terms of MNT provision. Who should provide MNT to your patient? Yeah, in the guideline, they clearly recommend that a registered dietitian, nutritionist, or international equivalent, in Indonesia you call it nutritionist, be it nutritionist, must work in close collaboration with nephrologists or physician and other providers, yeah, to provide the MNT. Okay, so this is level 1C, and also in terms of adverse clinical outcome is opinion based, and we should also use the evidence-based protocol, but all of these would require individualized modification. So we cannot use a blanket to all patients, and with, you know, with, it's good to see that. So it's good to see that in the guideline, they also highlighted, because of the current pandemic, they also highlighted that the MNT can also be delivered through other mobile applications such as telehealth. Okay, so let's move on to protein intake. I'm sorry, move on to protein intake. Yeah, let's move on to protein intake. So in the latest guideline, they highlighted that this stratified into 2 categories: those with diabetes and those without diabetes. Yeah. So for those patients with no diabetes, without diabetes, the recommendation is to go from 0.55 to 0.6 gram per kilogram body weight in order to reduce risk toward progressing to end-stage kidney disease and mortality, and improve the quality of life. And in some patients who will be able to afford the use of keto analogs, you can go slightly lower at 0.28 to 0.43 gram per kilogram body weight of in order for you to calculate the protein. All right. So, and you of course you have to supplement with keto analog. However, for diabetic patient, the recommendation remain higher at 0.6 to 0.8 gram per kilogram body weight in order to have a good or optimized glycemic control. How about for patient on PD and HD? For those patients on maintenance hemodialysis, the recommendation is the same regardless whether they have diabetes or not, at between 1 to 1.2 gram per kilogram body weight in order for them to maintain a stable nutritional status. Okay, how does this compare to the previous guideline? If we look into previous guideline by Penafree, for example, previously we had, a blanket recommendation, be it with patient for diabetes or no diabetes. But I think that as you may already aware of this, it's rather difficult, for patient, especially when patients don't really have a good glycemic control. You're trying to control their glycemic aspect, but yet you have to give much higher carbohydrate in order to compensate for low protein diet. So it's rather difficult. So it's good that this the current guideline do highlight about the difference between diabetic and non-diabetic patient. And in previous guideline, in latest guideline, it has more a little bit of liberty to give slightly a range of protein between 1 to 1.2 instead of 1.2 gram per kilogram ideal body weight for the previous guideline. And if you notice, in previous guideline, we do emphasize about the high biological value protein, but it is not for this guideline. So this is also in line with KDIGO guideline for CKD with diabetes, diabetic nephropathy, in which they recommend to maintain the protein intake at 0.8 gram per kilogram body weight. Yeah. All right. Let's let's just put into certain perspective. There are some points to ponder. The guideline was published in 2020, and in the same year, there was a review paper published in Cochrane database system about the implication of low protein diet to patients with CKD. So let's take a look into what this paper is saying. So this paper investigates the effect of low protein and very low protein diet on several heart outcomes. The heart outcome that they are looking at is, the first one is on the death, on the mortality, and the second one is on the progression toward kidney failure. All right. So if we can see here, based on the evidence that they analyze, it seems like low protein diet, doesn't really have effect on the death, on the mortality. And also in the same thing, when they look into progressing to end-stage kidney disease, seems like, low protein diet has no effect or neutral effect on low protein on ASKD per se. And the same when they look into the change of GFR, it seems like low protein diet doesn't confer any significant or beneficial effect in order to delay the progression or reduce delay the reduction in GFR. So what does it mean here? So why, this kind of evidence coming that are published in the same year can have different sort of interpretation? So I just want you to be more critical about it in terms of reading the guideline, particularly because we have to understand in terms of the numbers of study that are included in the analysis. For example, the guideline only included analysis from 1985 to 2016, in which, if you can see in this paper, there are some early evidence being included in this forest plot analysis. So definitely that will actually lead to different outcome of it. So those are some critical thinking that you have to put in when you're trying to read the guidelines. And the guideline is very much also advocate the use of keto analogs. They are recommend. Why keto analogs? Because many research have shown that keto analog is lack of the amino group bound to the alpha carbon of amino acid. Having said that, they can be converted to their respective amino acid without the need of additional nitrogen. Yeah. So having said that, keto analog has been investigated in terms of how it can help to improve the overall uremic syndrome of the patients. Yeah. And also reduce or delay the progression toward kidney failure. So, but we have to understand that using keto analog is very, very expensive. The prescription is that you have to give 1 tablet for every 10 kilogram. It is rather expensive, and for us in Malaysia, only few hospitals are adopting this. I myself also don't have experience with patient on keto analog, given the socioeconomic background of the patients, right? So you cannot go half and half dose, so that's not going to work. So you have to give a full dose. And on top of that, as I mentioned just now, what is there any different in terms of type of protein? Does type of protein play important role, make a difference in terms of, getting the recommendation? So in KDOKI guideline, they don't really recommend, or because there is insufficient evidence meaning there is evidence, right? Insufficient evidence to recommend any particular protein type, whether it's plant or animal-based type, based on this particular guideline. But again, the guideline was based until the literature up to 2016, right? So in the last 4 years, you'll be amazed that there are so many literatures pertaining to the plant-based protein that being emerged. And there are also several, review paper that has been published. There are some review paper that I would like to highlight here from the very well-known nephrologists. For example, they are highlighting that the plant-based diet can actually reduce the metabolic acidosis, can confer benefit in terms of controlling the blood pressure, can reduce the hyperphosphatemia, given the fact that phosphate from the plant sources is less absorbable as compared to phosphate from the animal sources. And having said that, they have also showing that plant-based diet can also lead to reduce in terms of uremic toxicity. It's better in terms of controlling of inflammation, particularly because of its high in antioxidant, can reduce the oxidative stress and so on and so forth. But there are some also challenges. Some of the plant-based diet may lead to hyperkalemia, may lead to the protein adequacy, kidney stone, and so on and so forth. So don't be surprised if your fellow nephrologists are asking you about, prescription of plant-based protein diet to your patients. So you have to be a little bit open-minded in this and considering case-to-case basis for your patients. Also, in terms, we moving on to the next thing. Sorry, I focus a lot in protein. So we move on to the next thing, which is the calorie. So in terms of calorie, the latest guideline is recommended between 25 to 35 kcal per kilogram body weight. Because the rationale is being because the range between 30 to 35, you can actually maintain an adequate neutral nitrogen balance and also nutritional status. And there are some clinicians that are really concerned about, overfeeding your patient. Overfeeding is also not good in that case. Yeah. So let's compare with the previous guideline. Previous guideline by Penefri in 2011 was, give a lot higher prescription of the energy at 35 kcal per kilogram ideal body weight, and you can give slightly lower at 30 if the patient is older and have sedentary lifestyle. Meanwhile, in the latest guideline, when they reduce it slightly lower at 25, I think that's provided some leeway for us not to overfeed our patients. Okay, so that is energy. We have covered energy and we have covered protein. So now let's take a look into what are the guidelines say about nutritional supplementation. Okay, so I can actually summarize this in one slide as well. Yeah, basically what they recommend is that for patients who require nutritional supplementation, first, before you ever talk about nutrition supplementation, you have to consider giving them diet counseling first, and try at least look at them, monitor them for at least 3 months before you embark them into oral nutrition supplementation. Yeah, oral nutrition supplementation, or ONS, here is referring to the kidney specific supplementation. And if you try them, with ONS and it seems like it doesn't work, so you may need to do the enteral nutrition supplements. Yeah. And if it doesn't work as well, you could try interdialytic parenteral nutrition and also TPN for your patient. All right. And also, the guideline also talk about the use of Dialysate protein energy supplementation. What it means is that you actually put the supplements in the Dialysate, right? So, but the guideline does not really suggest of substituting the conventional dextrose Dialysate with the amino acid Dialysate in order to improve the nutritional status of your patient. Right, so that is what the guideline is saying about it. And also, the guideline talk about a lot about some of other micronutrients, such as some vitamins, supplementations, and so on and so forth. But what is more obvious in the guideline is pertaining to the omega-3 supplementation, because that kind of have some positive results. So in terms of omega-3 supplementation, as far as mortality and cardiovascular disease is concerned, it is not being recommended by the guideline. As far as, to improve fistula patency, in order for you to avoid, the blockage of the fistula, it is also not recommended by the guideline. As far as for kidney transplantation patient, in order for them to improve the allograft survival, the new kidney survival, it is also not routinely prescribed. The only evidence exists is in terms of the lipid profile. So it seems that, omega-3 fatty acids seem to be able to reduce triglyceride, and LDL-C, and increase HDL-C. However, you have to look into overall perspective is, improving lipid profile is really beneficial for your patient overall. Okay. So it's a bit, disappointing that the current guideline, KDOQI guideline, did not really talk about the use of anabolic agent. And when I look at the PENFRI guideline, it is interesting that in PENFRI guideline, they talk about, the use of anabolic agent in order to improve the appetite of your patients. Yeah. So they recommend that androgen to be given on the weekly or twice monthly. Yeah. On certain dosage. Right. So let's take a look. Okay, we are done about nutrition supplementation. Let's move on. We don't have much time. Let's move on to micronutrients. Yeah. So this is basically, I just want to summarize about the micronutrients. So overall, in terms of micronutrients for CKD3 to 5D and also post-transplantation, they recommend and highlight that the need to eat a food that are, to meet the diet that to meet the RDA requirement, basically. Of course, it has to come from the soul food first. However, upon assessment, if you found that your patient have some, sign and symptom pertaining to the inadequate or insufficient intake of certain micronutrients, yeah, you may supplement them with multivitamins or certain isolated vitamins, um, according to their RDA. You are not going to give them mega doses of vitamin. You just follow the supplementation according to the RDA. For example, if RDA of vitamin C and your patient is having scurvy, sign of vitamin C deficiency, so you may want to supplement it up to 75 milligram per day of vitamin C, right? Not 1000 milligram per day. Okay, so that is in general about micronutrient prescription for your patient. So you can read further in the guideline, in which I think I'm not going to have much time to talk about all of this. Okay, how about electrolytes? So for electrolytes, what they recommend for CKD 3 to 5 is 800 to 1000 milligram per day for calcium. And you have to consider all calcium, not just from diet, and also from the from the phosphate binders, from the calcium supplementation that the patient actually taking as well. Yeah, and for phosphorus, yeah, they are, and also potassium, they are recommended to adjust the phosphorus intake to maintain serum phosphate level within the normal range. All right, which is, this is a bit different than what we previously said about the previous guideline. Actually, in previous guideline, we have a certain recommendation, the range for phosphorus level and also the range for potassium level. But it is not the case for the latest guideline, in which I personally think it is better in that sense, because we can only adjust it once our patient level is high. So that provide a lot more liberal diet for our patients, so they don't end up with restricting everything. All right. The same goes with potassium. And for sodium, the recommendation is that the total sodium intake to be less than 2300 milligram per day in order to improve the volume control. And then this can be achieved by modification of lifestyle, strategy, and so on. All right. All right. So when we talk about phosphate just now, I'm sure that one of the approach that you can have is to have more practical guide to the patients. So what we have here is one of the book that we published a couple of years ago in order to help our patient controlling their phosphorus. We do emphasize about the inorganic and organic phosphorus, in which the absorption from inorganic phosphorus is much higher. It can be up to 100%. So you want to advise your patient about taking all those processed food. Meanwhile, you can see here, although some plant diet can be quite a rich source of phosphorus, but the absorption can be only between 10 to 30% as opposed to inorganic phosphorus. And then we think that, the use of traffic light system kind of help a little bit. Traffic light red here, it doesn't mean that it has to stop and it has totally avoid it. What it means is that they have to be extra careful about it, and they have to count the numbers of red. So they don't want, we ask the patient not to exceed more than 10 red dot in a day. All right. So based on this list, they can actually count how many red dots they actually have in a day, so that provide more leeway for them to plan their diet accordingly. For example, if they are having spaghetti bolognese with 7 red dots for their lunch, so definitely they only have the less than 3 red dot that they can actually do for the next meal. So they have to think about how they can actually navigate around it. Okay, and of course, we also talk about the importance of food preparation technique as well. There are some food preparation techniques such as boiling. The boiling water can actually reduce the amount of phosphate in the diet. Okay, so we give them some typical day advice. So this is their typical day. And how about if we modify it with certain type of food, for example, roti canai with telur, that's provide 2.5 red dots. So if we modify it with toasty, for example, so that's just a yellow. So they don't really that overall cut down into their phosphate intake and help into bringing down their phosphate level, blood phosphate level to the normal level. All right, in terms of potassium, it's also important to highlight that, you know, many people are worried about potassium because it can have some immediate effects, such as, you know, having tachycardia, have issues with the heartbeat and so on, right? But we have to also be bear in mind that when we talk about high potassium or hyperkalemia, yeah, most of the time, many of our patients get hyperkalemia is not really related to diet. So it's important as a dietitian, we have to investigate on non-dietary factors that can actually cause hyperkalemia. For example, you want to take a look into the use of certain medications such as beta blockers, where's the insulin level of the patient, whether the patient experiencing hyperinsulinemia, whether patient is experiencing hyperosmolarity, and so on and so forth. And in fact, the technique when we draw the blood of the patients that lead to the lysis of the sample could also lead to error result in reading the blood potassium level. And you may also want to investigate whether your patient suddenly involved in strenuous exercise, because that can also lead to hyperkalemia. And take a look at whether patient experience constipation, because one of the way for us to defecate or remove potassium from the blood is through defecation as well. And you want to take a look whether there are IV fluid, especially in hospitalized patients, that are being used. So investigate and identify all those non-dietary factors first before you look at the diet factors that contribute to hyperkalemia. So of course, when diet factors is the fault there, you can impose temporary restriction on the high potassium food. But bear in mind though, it's kind of challenging for us in dietitian to refer to this list as well, because potassium level from one country to another can be differ, because it's actually based on the soil of, you know, of where your vegetables, where your fruits coming in. Yeah. So these are some summary guide that we can actually use to educate our patients about potassium level. But please bear in mind, you have to revisit your patient, because you don't want them to follow a monotonous diet restricting pretty much fruits and vegetables. You don't want that. Yeah. So you can also educate them on some of the techniques to reduce the amount of potassium. For example, boiling technique here, if you apply it to potatoes, for example, and you discard the water, it can reduce up to 75% of the amount of potassium from the original non-boiling potatoes. And more importantly, sodium intake. The guideline says that the sodium should be limited to less than 2,300 milligram in a day. Based on PERSAGI guidelines, it is kind of interesting that in PERSAGI guideline, instead of sodium, you are highlighting about sodium chloride, which is salt. Well, it is understood that for salt can be the major source of sodium in our diet. But for our perspective, from Malaysian perspective, at least, is not always true, because many of patients actually using, food enhancer such as monosodium glutamate, and many of them are using processed food as well that are high in certain chemicals such as sodium benzoate and so on and so forth. That is also can contribute to the sodium in a diet. So we just need to be extra careful on that when you talk about sodium. It's not just about sodium chloride, which is from your salt. Yeah. Why is it important to control the sodium intake? Because we want to improve the blood pressure, we want to improve the volume control, and for those CKD 3 to 5, you want to reduce the proteinuria together with your pharmacologic intervention. So almost getting there. Okay, just a few more minutes before I end my presentation. So ladies and gentlemen, as what Professor Winnie just said just now regarding the role of dietitian for kidney patient, we know that renal diet is very, very complex. You got to talk about all the micronutrients, you got to talk about protein, all of those and different level of protein as the patient progress from CKD to dialysis to transplantation and so on and so forth. So, to translate this knowledge to a practical advice to you patient is very, very complex and required a lot of practice. However, we are from low and middle income country where we have our own challenges. We have challenges in delivery of all of these, what the guideline says, where the guideline derived from the Western country to our setting in a low and middle income country. Based on the recent survey by ISRNM and also ISN, that they survey about 182 countries worldwide and 155 countries responded to the survey. They are showing that less than half of these countries have dietitians. And out of that, when we look into LMIC, low and middle income countries such as Malaysia and Indonesia, only 23% of our patients, never have dietary counseling at all. Yeah, and 41% of the country did not even provide a formal assessment of their nutritional status when the patient began their journey as a kidney patient. Yeah, so that is a very alarming, a very issues that we have to address as overall as a nation. Let's take a look into what the outcome of the survey slightly later. Okay. And once we say about, that the advice that we give to the patient, what more important is we have to look into the aspect whether our patient can adhere to our recommendation or not. We just recently published on this paper on about nutrition literacy and how it's actually linked to the dietary adherence. So we know that dietary, in interprofessional model, it's not just us as a dietitian providing treatment to our patient. It also comprises of, dialysis nurses, our nephrologists, medical doctors, and so on and so forth. In terms of when we look into treatment adherence rate, those who come to HD treatment 3 times in a week, 4 hours per session, that is about 70%. And when it comes to the medication, the adherence to the medication prescribed by the doctors, that is about 74%. However, it's very pathetic when we look into our role as a dietitian nutritionist, when we look at the adherence to our advice to the patient on the fluid restriction, on a dietary prescription, that doesn't even reach 50%. So it is very alarming to see that. And why is that so? So we conduct a study about 200 patients in Malaysia, and the study are representing the ethnicity in Malaysia and also the socio-demographic factors in Malaysia. So what we found that among those patients, there are 46% of our patients actually have limited nutrition literacy. And when we compare it with general healthy population, general healthy population reported by our National Health Mobility Survey is about 25% of them having limited health literacy. And when we put more in a statistical model to find what are the factors that are associated with this health literacy, we found that nutrition literacy is an independent factors associated with dietary adherence. So ladies and gentlemen, it's very important to also address on the issues of nutrition literacy of our patient. So when I say nutrition literacy, what does it mean? It basically simply means that when you give a lab result to your patient should be able to tell, where is this phosphorus, or where is this potassium related to from their diet? What are the sources of potassium? What are the sources of phosphorus, and so on and so forth. When they go to the grocery to buy stuff, and they should be able to read the label of the product, right? So all of those are component of nutrition literacy that we would expect our patient to be able to understand and grasp this concept before we give them advice on particular restriction on that, particular nutrients of interest in kidney patients. So how do we address on that aspect? As nutritionists and dietitian, some of the way that we could do that is by tagging our patient with the red flag. Some of the patient may require further, intervention to improve their nutrition literacy. For example, if a patient come to the clinic, and this patient, when you ask about medication, some patient, when we talk about medication, they are pretty open to us to talk about medication. But if they talk to pharmacists about medication, they will not tell that they actually don't follow the medications. It's the same thing. They can be very open to pharmacists talking about diet, but when it comes to dietitians, they try to cover up a little bit because they kind of expect that they didn't eat what dietitian expect them to eat. So you can give a red flag, if they are saying that they are not adhering to certain type of medications or miss up the appointment, for example. So those are very much red flag. And when throughout the counseling session, when they don't ask you any question, they just silence all the time, that is also red flag. They probably don't understand a word that you're talking to them. Yeah. And if they can't even name their medications, and then if you can give them education pamphlets for them to read, and they are saying like, I forgot my glass and let me bring home, I can ask my kids to read from me. So those are definitely a red flag that your patient are probably having issues with their nutrition literacy. All right. So how do we improve nutrition literacy in our patient, right? So one of the way is to actually use the technology. So this is one of the product that we develop. Me and my team develop using apps. Yeah, if you're interested, you can scan there, and it actually bring you to our video about the app. So you can see that you can patient can key in certain food that they're eating, and importantly, this app is all the food database. All the food that are being eaten in Malaysia are there. So they can, and then the app will give an immediate feedback to them. What about their energy level? What about the protein level? Whether they actually meeting the recommendation and so on. So once they click on that, the app will tell to them where is their problematic food, and how they can actually change to another type of food in order to improve their overall food intake. Okay, so a few more slides. Hopefully you bear with me. So another thing is, as we are approaching to Ramadan fasting, this is another big topic that we nutritionists, dietitians have to talk to our patient. So we recently published a couple of papers pertaining to Ramadan fasting among HD patient, to be exact. So we know that for HD patient, when we look at what being recommended by the guideline, you know, when having advanced CKD or patient on HD, even patient on CKD stage 1 and 3, if they have unstable kidney function and they are hyperglycemic, for example, that is a big no-no for them not to fast during Ramadan. But, you know, patient being patient and us being, if you can put ourselves into the patient's shoes, many of our patients, based on the survey that we just did, 80% of our patients will fast anyway, regardless what you say to them. So they will fast anyway. So rather than saying no to them, you have to understand why is that the reason for them to fast. Many of them fast because they feel like, you know, they just want to be like the rest of their family. You know, they want to get the redo, yeah, from the God. So all of those are some of the reason why they want to fast. Yeah. So definitely we have to talk to our patients. So how to talk to our patients? Yeah. Ask them whether they plan to fast or not before Ramadan, and explore why is it, what was the main reason for them to actually fast? Is it because they're spiritual, because of the, you know, peer influence or peer burden that they're experiencing? And then you stratify the risk of the patient, whether they are in a good control of if they are diabetic, in their good control, they have any issues with hypoglycemia and so on. And even if most of likely our patient will fall in a very high risk and high risk, and then you can explore some of the alternative for them. Maybe you can advise them, you know, instead of fasting every day, maybe you can fast on non-dialysis day only. Maybe you can try out a few days before Ramadan, all right? And then perhaps you can explore on the fidya aspect, yeah? So some of the advice that you can give to your patient, for example, you can consider them to try fast, you know, even before the Ramadan is begin. And you have to advise them what happened during fasting if they suddenly feel sign and symptom of hypoglycemia, how do they address that, and so on and so forth. What are the medication? Talk to your pharmacist as well. What are the adjustment of medication that they have to make? In terms of the use of first aid binders, for example, you can advise them when they can actually take the first aid binders, and so on and so forth. So all of those preparation are needed before they even go to fast. So that is our role, ladies and gentlemen, as dietitian. We have to do that fast before, because we only have a couple of days left before we go for Ramadan fasting. So some other aspect that we have to consider is that if your patient, you are subjected to too many dietary restriction, they will end up with eating the same food day in, day out. And we have to acknowledge this, that eating the same food day in, day out is not necessarily a good thing, because it can lead to diet monotony. And the study have found that if our patient is following diet monotony, it is a high chance that they are not going to meet recommendation for energy and protein intake, and will end up getting protein energy wasting. So ladies and gentlemen, we really have to address on these issues. Our study, when we look into the dietary patterns, and we are based on over 200 patients, and we found we can divide the diet pattern of our Malaysian dialysis patient into 4 categories. Those who are following home food pattern, meaning that they are cooking at home, yeah, and they are eating all sort of things like this. And those who are eating out, but mainly rice-based type of food. And those who are eating out, but you know, in their diet is predominantly having sugar-sweetened beverages. You know, they have teh tarik. Teh tarik is Malaysian favorite. And those who are eating out, but mainly noodle-based. This is typical, very typical to Chinese patients especially. So after our based on this diet pattern, and we found out that those who are following home food had more superior in terms of controlling all of those their biochemical parameters, especially on phosphate level. They are well controlled when you compare to The worst is eating out with a sugar sweetened beverages. Yeah. So how does that to sum up, how does that aspect highlight the role of dietitians and nutritionists? We definitely has to advocate, cooking at home. You conduct like a cooking lab, cooking techniques, cooking workshop with them. All of those going to play back the basic role of dietitians. Okay. Finally, I managed to finish. All right, with that, thank you very much. Before I end up my presentation, I would really love to give some acknowledgement to the pump tocotrienol in chronic hemodialysis study, because based on this study, I managed to travel to many countries, to Malaysia, US, Bangladesh, India, because it's just not one-off visit. We have a multiple sort of visit. For example, in Bangladesh, we have over 5 visits over 2 years period. And we conduct in Bangladesh, interestingly, they don't have dietitians. So a lot of help is needed there. So we did a lot of human capital development with people in Bangladesh as well. That's my team in Bangladesh. We did a development on food frequency questionnaire, on a recipe book for kidney patient, and many things. Yeah, and more or less we train dietitian, we train nephrologists and doctors to do nutrition screening and nutrition assessment for the patients. And I also got a lot of support from the nephrology community in Malaysia. I can't really thank them much. And also my new collaborators in Universitas Gajah Mada, especially to Dr. Suzy, for her help in my survey as well. With that, thank you very much. And before my second last slide, just to promote that we're gonna have our MDA conference, Malaysian Dietitian Conference. So please do register and submit your abstract if you are interested with this.
Thank you, Dr. Zulfitri, for the presentation. It was amazing, quite comprehensive, I would say. And we'll definitely share about the posters that you mentioned at the end of your presentation. So I'm going to say a few things from his presentation earlier. So we learned, how to adjust the dietary intake for our chronic kidney disease patients, the protein intake, energy intake, micronutrients, electrolytes, and others, including the plant-based diets and also nutritional supplementations that he mentioned were very, very interesting. And I would like to mention again also one of the updates that he mentioned. We should adjust the dietary phosphorus and potassium to maintain the normal serum levels instead of sticking to the calculation in the guidelines before, because electrolytes, like he mentioned, especially potassium, are easily influenced by non-dietary factors such as medication and other medical conditions. Last, another reminder also was on the sodium sources. Seperti yang Pak Zulfitri sebutkan, garam itu bukan hanya garam makan yang di atas meja, tetapi sumbernya banyak, seperti saus kalau di Indonesia, bumbu instan, dan lain-lain. Kemudian, to make sure that the patients are following the dietary prescriptions that we have created as their dietitian, we have to make sure that they have nutritional literacy, because otherwise it would be a little bit useless because they won't stick to our diet prescription. Okay. Before we discuss, because I've seen the chat box and there's so many questions for Professor Winnie and Pak Zulfitri, we will come back and answer those questions after we have the next presentation from a practitioner. Thank you, Pak Zulfitri. I'm going to continue with the next speaker. So the next speaker is Pak Yudi Adrianto. He is a practitioner at the Dr. Cipto Mangunkusumo Hospital in Jakarta. He is going to speak on a case study about the implementation of nutrition care process in patients with chronic kidney disease. We know that Dr. Cipto Mangunkusumo Hospital is a big hospital, and I understand that other nutritionists or dietitians in Indonesia always follow to Dr. Cipto Mangunkusumo Hospital. So he's going to speak on the case study that he has done. He's an experienced nutritionist. He had several publications, and the most recent ones were on chronic kidney disease patients undergoing continuous ambulatory peritoneal dialysis. So please give a warm welcome to Pak Yudi. Time is yours.
Okay, thank you, Nurul. Assalamualaikum warahmatullahi wabarakatuh. I'd like to share my screen. Yeah, first of all, I would like to say thank you to PERSAGI and KTKI that have invited me in this wonderful seminar, and also to Prof. Winnie and Dr. Zul. It's been an honor to meet you here, even in virtual. Okay, I'd like to share you my experience in case study on CIPD patient with peritonitis. Yeah, in Indonesia, most of the CKD patient, especially in end-stage renal disease, undergoing with dialysis or hemodialysis. But not only hemodialysis is the renal replacement therapy for CKD patients, but also peritoneal dialysis have been used to as the renal replacement therapy for CKD patients. Okay, now we have to look what is the physiology about the peritoneal dialysis. Yeah, the physiology introduction about the peritoneal dialysis is a treatment for patients with severe chronic kidney disease. The dialysis is using a technique that use the patient's own body tissues, peritoneal membrane inside the abdominal cavity as a filter. So the semi-permeable peritoneal membrane allows solids and water to be transported from the vascular system to the peritoneal cavity and vice versa. The principles underlying peritoneal dialysis have three processes to take the simultaneously dialysis. First of all is diffusion. Diffusion makes the high concentration throughout to the low concentrations, and osmosis, especially from the glucose, the dialysate fluid that contains of glucose in CIPD patients, generate a high osmotic pressure, which induce ultrafiltration from the capillaries, especially blood, to the peritoneal cavity, and the ultrafiltration process. The exchange process included three processes, which is infusion of dialysate. This is the dialysate solution bag of dialysis, and the dwelling, which is the CIPD fluid entering the abdominal cavity, and we can change. We can say it changing process of the dialysate water, and then the drainage to secrete the dialysate fluid that have been saturated and changed with the new dialysate fluid. Yeah. About the dialysis-related problem in CIPD patient, especially is protein loss. Protein loss through peritoneal membrane research shows 6 to 12 grams per day in peritoneal disease patients. And to compensate, the PD patient must and need to eat between 1 to 1.2 grams per kilograms body weight per day. And the loss is increased during peritonitis. And now we are going to talk about the peritonitis case. Another substance that will be lost during the dialysis process is water-soluble vitamin, especially vitamin B, C, hormones, and some drugs or medications. Before we are going to discuss the case study, we have to know what is the peritonitis in peritoneal dialysis patients. Peritonitis is most common and most serious complication in peritoneal dialysis patients, and the diagnosis generally is include PD effluent, and the patient signs and symptoms with abdominal pain and tenderness in abdomen, and identification of microorganism in PD effluent in culture or positive gram staining. So the infection of microorganism in peritoneal dialysis patient, the risk is high, and it is shown in peritoneal dialysis fluid. Yeah. Peritonitis is an inflammation or irritation of the peritoneum, the thin tissue that aligns in the inner wall of abdomen and covers most of abdominal organs. In etiological factor, the causes of peritonitis, first of all, is bacterial infections, especially gram-negative bacilli, such as E. coli, and medical procedure, peritoneal dialysis. And the last is ruptured appendix, stomach ulcer, colon perforation, or trauma that makes bacteria transport into peritoneum throughout gastrointestinal tract. And the risk factor of peritonitis is previous history of peritonitis. If the patient have the history of peritonitis before, and history of alcoholism and liver disease because of fluid accumulation or STS. The peritonitis is one of the major complications of continuous ambulatory peritoneal disease or CIPD. It's an inflammation of peritoneum, the thin tissues that line inner wall, and it's majority caused by bacteria infection, either via bloodstream or of the rupture or abdominal organ. Signs and symptoms peritonitis including swelling and tenderness in the abdomen with pain ranging from dull just to severe, sharp pain. Other symptoms including fever, chills, and loss of appetite, thirst, nausea, vomiting, less urine, and not being able to pass gas or defecation or stool. The first primary step in treating peritonitis is determining its underlying cause. Treatment usually involves antibiotic. So we are going to discuss the case study of the patient with peritonitis in CIPD. Yeah. The case study is a 38 years old male entering emergency room with severe abdominal pain since 3 days. He has milky dialysate effluent. And the physical examination, blood pressure 130 per 98 millimeter Hg, and pulse 104 per minute, saturation 99%, and temperature is 38 Celsius. With eyes, pale conjunctiva, no icteric scleria, abdominal sociable, bowel sound normal, visible CIPD access area covered with bandage, tenderness in area of CIPD, liver and spleen not palpable. In the extremities of the patient, he has a warm acral, the edema of lower limbs, lower 1/2 of courage to pedis. With dialysis history, the patient input Dialysate 2 liter with output 2.2 liter to 2.4 liter, with Dialysate fluid concentration 1.5 3 times and 2.5 1 times at night. Then the patient urine output is 700 cc per 24 hours. Next to the patient history, the patient have nausea and vomit. The patient nausea and vomiting denied. Liquid defecation has been present since 1 week before admission. So the patient has liquid defecation and no blood and mucus. The patient admit that he had milk, shortness of breath, no chest pain, cough, runny nose, painful swallowing, and anosmia. Denied contact with history of COVID-19. Currently, there are still complaints of abdominal pain, fever that comes and go, and there are no liquid defecation since 2 days ago. The patient was known to have kidney problems since 5 years ago. Complaints of paleness, and from laboratory examination, there was a decrease in sodium and potassium. On around early 2021, the patient complained shortness of breath, weakness, swelling in the hand and feet, edema, The patient was treated with hemodialysis initiation on January, and the patient was advised routine hemodialysis twice a week. But the patients prefer CAPD than doing the dialysis with hemodialysis. The patient admit that the last 3 to 4 months he complained of fatigue. Usually after going up 10 stairs of the patient immediately just spend the night. The patient now have suffered from hypertension since 30 years ago. So the underlying disease of the CKD of the patient is hypertension since 30 years ago. Currently, the patient regularly takes amlodipine, candesartan, and spironolactone. The patient is married, has 3 children. The patient's wife and the patient's first child suffer from hypertension. Healthcare and habits: currently not working, use as self-employed, which is selling groceries, and the patient has smoking habit from 10 years ago. So hypertension and smoking habit is the patient major problem about the risk of CKD. Here is the laboratory result. And the medication therapy of this patient, the doctor give to check the electrolyte during 3 days, follow up about fluid culture of CAPD, and another therapy using the CAPD Dialysate 1.5-2 times and 2.5-2 times. So the 4 times of CAPD dialysis using 1.5 and 2.5 with supplementation of multivitamin, especially vitamin B and folic acid. Yeah, before we are going to discuss about the medical nutrition therapy and nutrition care process to the patients, we have to see the risk of malnutrition, or we have to determine the patient is malnourished or optimum. So we are continuing with the patient's nutrition screening. The nutrition screening that can be used in many other healthcare facilities, and maybe in general healthcare facilities in Indonesia using MST. The MST questions is the first ask the patient about the weight loss, and then the second about the appetite of the patients, and the MST categorized as three categories. The first of all is low risk, MST 0 to 1, medium risk 2 to 3, and high risk, MST 4 to 5. And all of the patient with CKD should give the nutrition assessment or dietary consultation with the dietitian or nutritionist. Yeah. The nutrition care process by International Confederation of the Dietetic Association, including with nutrition assessment, nutrition diagnosis, nutrition intervention, monitoring, and evaluations. So, what the distinguish between the nutrition assessment or nutrition care process of for example, a diabetes patient and a CKD patient, or especially in this case is CKD patient. So we have to take a look about the assessment of the patient. Yeah, the first initial assessment we have to do and examine the subjective global assessment of the patient. Subjective global assessment, after we are informed about the malnutrition, or we are validating about the malnutrition screening tool of the patient by the information of the nurse, we have to assess the patient's nutrition status using the subjective global assessment. Subjective global assessment includes 7 components, which is the first of question is weight loss during 6 months. The second is gastrointestinal symptoms. Third is food intake. The fourth is functional capability. 5 is comorbidity or duration of dialysis, and a physical examination, which is loss of subcutaneous fat or the presence of muscle wasting. After we are doing the subjective global assessment, we see the patient's other assessments such as biochemical assessment, and then we can interrelate the both of the subjective global assessment and another biochemical value assessment such as albumin, TIBC, and also it can be used for scoring the malnutrition inflammation. Here is the malnutrition inflammation score, which is another screening for KD patient that I usually use in both of hemodialysis on CIPD to see the severity of inflammation that the patients suffers. Yeah, it is including same question with the SKA, but with an addition of body mass index, laboratory parameters such as serum albumin and serum TIBC atau total iron binding capacity. After we are doing the SGA, MST, we are conclude the patient's nutritional status. We doing the nutritional assessment, which is start from anthropometric data. From the data, we got the body weight patient is 48 kilograms and age with 160 with BMI 18.7, and the patient is at risk underweight. But the patient with decrease of body weight 7 kilograms per 6 months, or 12% of decreasing body weight per 6 months and inadequate intake. And the patient suffers of edema in both of his legs. So the dry body weight is 45 kilograms and the BMI patient is 70.5 kilograms per liter. And the patient is underweight and high risk of malnutrition. From biochemical data, it seems that the result of biochemical tests show the patient is in peritonitis, especially because of CIPD infections and anemia renal, hyponatremia, and hypoalbuminemia. In nutrition assessment, after we are doing the anthropometric data, biochemical data, we are collecting the physical or clinical data related nutrition. We are assess the physical or clinical data related nutrition. First of all, the patient have intentional weight loss 7 kilograms per 6 months, which is decrease because of decreased appetite. The patient have edema of lower limbs and no presence of diarrhea. Complaints of abdominal pain, no presence of nausea or vomiting, loss of temporal orbital muscle, subscapular, clavicular region, triceps, and the patient is malnutrition. After we are doing the physical clinical data related nutrition, we have to examine the dietary assessment to the patients before his admission into the hospital. The dietary assessment of the patient before admission, patient usually eat 3 times per day, but have received nutrition education related diet, but the patient have inadequate intake since 3 days before. Patient only eat only half portion of meals, 2 portion of protein source per day, calorie vegetable, no snack, and fluid intake from sweet tea 500 milliliters and drinking water 500 milliliters. So the patient intake estimated energy is 1035 kilocalories, which is 285 kilocalories compensated from dialysate fluid, and the protein is 20 grams, fat 10 grams, and carbohydrate is 145 grams, and 71 grams from dialysate fluid. So after we assess the nutrition, especially the dietary assessment, we can calculate the nutrition needs of the patient, and when we can compare which is the intake, it is adequate or not. The nutritionist of the patient from the micronutrients, energy 1,900 kilocalories. We are using 35 kilocalories per ideal body weight and protein 65 grams. But because of the peritonitis, the target of protein can be increased to 1.5 gram per ideal body weight. The fat is 52 grams and carbohydrate 289 grams or 61%. With micronutrients, vitamin B, folic acid, vitamin C, and minerals to be consumed is NaCl or natrium chloride, salt, 5 to 10 grams per day. And not only salt in salt, kitchen salt, but also in seasoning such as soya, such as sauce, and potassium 8 to 70 milligrams per kilograms per day, calcium less than 2,000 milligrams per day, phosphorus 800 to 1,000 milligrams per day, and zinc is 12 milligrams per day. The patient, because of due to edema, it is restricted to consume 100 more than 100 milliliter fluid, and it must be monitoring in 3 days. So the nutritional diagnosis of this patient is malnutrition related to increased nutrients due to chronic and infection illness, as evidenced by underweight, unintentional weight loss, more than 10% per 6 months, muscle and fat loss, energy intake less than 50% of estimated requirements, and with peritonitis and CFPD. So what is the nutritional intervention to this patient? The outcome, we have to address the increased nutrition intakes. To increase the nutrition intakes of the patients, more than 18% of nutrition requirements, and body weights are normal and gradually. The implementation, the patient we can give the patient with high protein dialysis diet 1,900 kilocalories per day, which is from the diet oral 1,100 kilocalories 3 times meal and 2 times snack, with extra protein 2 portions from the white boiled egg. And the patient is recommended to consume oral nutrition supplement, which is the recommendation is 10 kilocalories per area body weight or 540 kilocalories. And it can be given by consume dialysis formula meal, for example, 2 times 150 milliliters, which is formula 1.6 kilocalories per milli to 1.8 kilocalories per milli. And the complex supplementation and fluid restricted from diet is 750 milliliter per day. And about the CAPD and hemodialysis, what is the difference? Because the CAPD is used the dialysis fluid that contain dextrose. So we have to calculate the energy intake of the patient by the intake of the dialysis fluid. The patient is given CAPD diurnal fluid concentration 1.5, 2.5, 1.5, and 2.5. The concentration is increased both of the 1.5 and 2.5% of diurnal fluid because the patient have edema. So by the high concentration of dialysate fluid, it hopes can decrease the edema that happen in patients. And what about the dialysate energy intake? The dialysate of the peritoneal dialysis contains of dextrose, which is we have to calculate it as energy intake. Glucose absorbed from the dialysate CAPD fluid is estimated 60%. Not all of the 100% of dextrose will be absorbed and used as energy into the patients, but only 60% that they use and absorb as energy. For example, 1.5% of renal fluid only contains of 31 kilocalories. 2.5% of dialysate CAPD only contains of 51 kilocalories. And the nutrition intervention of the patient, we can calculate and we can divide it with meal, ONS, dialysate, and the total calories of the patient that we are given intervention is 2,100 kilocalories or 59 kilocalories per ideal body weight, and the protein is 68 or 69 grams per day or 1.3 grams per ideal body weight, and the fat is 49 grams or 21%, and carbohydrate is 333 gram or 63%. From nutrition intervention, diet given as recommendation, energy is more than 35 kilocalories per ideal body weight, and protein more than 1.2 grams per ideal body weight. The target of protein of this patient is 1.5, but due to the nausea or the required intake, we given the nutrition intervention in gradually. So we can increase gradually the nutrition intervention. The ONS recommendation is 10 kilocalories per ideal body weight, and from the diet is provided 9 kilocalories per ideal body weight. ONS is given to malnutrition dialysis patient to prevent energy protein wasting. Here is the algorithm of nutrition support in GKD. When the patient gastrointestinal tract is in good condition, we can give the enteral nutrition. If the patient in super condition or in coma, for example, we can give the enteral nutrition by feeding tube. And if the patient is in good or in metabolically stable patient, or we can give the enteral using oral food or oral nutrition supplementation. But if the gastrointestinal tract is not functional well, we can use the total parenteral nutrition to the patients. In peritoneal disease, we can use by intraperitoneal dialytic nutrition. So when the patient change the diurnal fluid, we can give the parenteral nutrition, and we can give the oral or enteral nutrition to the patient during the patient the patient do the dialysis process. Yeah, related to oral nutrition supplement, oral nutrition supplement is used to prevent wasting in hemodialysis, but it can be also used in COPD patient because of the energy intake, for example, lack of less than 30 kilocalories per kilogram body weight, protein less than 1 gram per kilogram body weight per day. Yeah, about the ONS, recommendation oral nutrition support formula, ONS requirement is given if food intake is inadequate. We can start it at 10 kilocalories per kilogram ideal body weight and protein 0.4 grams ideal body weight. And formula can be food or liquid, which is rich in energy and protein, such as snack bar or pudding. On dialysis, high energy and protein density food is recommended. About the administration, it can given as a substitute for fluid intake. So the fluid intake from the mineral water or sweet tea of the patient can be changed with ONS. And on dialysis can be given during dialysis or interdialysis. And the complication, ONS administration rarely cause interdialytic hypertension or vasodilation in stable condition. Again, in stable condition. Same as the previous material recommendation from Mr. Zul, in patient with CKD, especially in dialysis, we have to restrict the sodium intake less than 2,300 per day. And what is the high sodium? High sodium in especially in table salt, seasoning, canned food, which is using the natrium benzoate, pickle, salted snack, and most restaurant food, takeout food, or fast food. So we have to see the nutrition facts and the content of the sodium of the food. This is the less sodium or none, such as fresh food, fruit, vegetables, meat, fish, frozen vegetables, fresh seasoning, and fresh or dried herbs, or such as basil, bay leaf, curry, ginger, and unsalted popcorn, such as this is the example. And about the post-sport recommendation, the diet recommendation of post-sport intake is 800 to 1,000 milligrams per day. In hemodialysis, a process remove 600 to 1,200 milligrams per session. But in peritonitis, remove 300 to 360 milligrams per day. So the hyperphosphate in peritoneal dialysis has higher risk than the hemodialysis process. And the phosphate binder is usually given in patients with dialysis to maintain the phosphate conditions in the body and to control the phosphate. Yeah, about the potassium recommendation, different with hemodialysis patient, the potassium level in peritoneal dialysis patients seems to be lower than hemodialysis patients. The patient with CIPD, we are suggest to eat food with high contents of potassium. So the potassium can be maintained at normal level. This is what are the high potassium foods, such as fruit, bananas, melons, or kiwi, mango, papaya, and vegetables such as avocado, tomato, and then dried fruits, for example. Another in milk, yogurt, nuts, and seed, chocolate, and salt substitutes. This is what our lower potassium food. This is especially recommended for hemodialysis patients. And for the monitoring and evaluation of the patient, we have to monitoring and assessment of nutritional status, the SGR or MES of the patient, optimization of dialytic treatment to the patient, which is the patient increase the percent of diurnal concentration fluid, the management of comorbidities, such as if the patient have diabetes mellitus, for example, or cardiovascular disease, nutritional counseling that can be given by nutritionist or dietitian to the patient throughout the diet, what is need to be consumed to the patient because of the peritonitis condition, physical activities, what is the activities that can be done, and exercise of program to the patient. The nutritional intervention, if dietary intake is less than 1 gram per kilogram per day, or energy intake less than 30 kilocalories per kilogram per day, or the marker of albumin or prealbumin as a marker of inflammation less than normal, or non-intentional with loss more than 5% in 3 months or 10% in 6 months, and malnutrition identified by SGR or MACE, we can start using the oral supplementation, both of intradialytic or intradialytic, with target of a protein intake more than 1.2 grams per kilogram per day. In peritonitis case, it is can be given 1.5 gram per kilogram per day. So after start oral supplementation to this patient, we are monitoring the biochemical markers and body weight. Maybe the patient increase in body weight and the muscle is must increase, and no change or worsening of nutritional status. And if there is no change or worsening nutritional status, we can give the intensivity therapy to the patient by increased oral supplementation or start parenteral nutrition or using enteral nutrition to the patient. But if the patient biochemical and body weight and muscle mass have been corrected by the diet, we can maintain the nutritional goal, such as with albumin more than 4, albumin more than 30 milligrams per day in inflammatory factor, and dietary protein more than 1.2 grams per kilogram per day, and energy intake more than 30 kilocalories per kilogram per day. That is the monitoring and evaluation for the patient. I would like to acknowledge to my PD team in Cipta Mangunkusumo Hospital. We are used to have a round together with nephrologists and senior renal dietitian, Ms. Triani Krisnawan, and also the pharmacist and nurse in renal units. We also doing the home visit to the patient, both in virtual and real home visit to the patients. This is my CPD team in Cipta Mangunkusumo Hospital. Thank you. I'll give the notes to moderator.
Thank you, Mas Yudi. That was an outstanding presentation. We hear from him about the nutrition care process further using several case studies. So I will not summarize his presentation though, because I know we are running out of time. So I would like to invite Pak Zulfitri. Are you still here with us so that we can start the Q&A session with the attendees? So for those who would like to ask your questions live, we'll allow perhaps 3, but we'll see if we still have the time. Again, if you feel more comfortable asking your questions in Bahasa, feel free to do so. I will help you translate it into English for the speakers. I'm going to start with Pak Zul first. I would need the colleague to pin his screen, please, to join me and Mas Yudi here. Thank you so much. So I was very interested when you were talking about the plant-based diets. In fact, in Indonesia, the doctors often advise patients with chronic kidney disease and those undergoing hemodialysis to avoid fruits and vegetables. I think one of the attendees named Yushi Winarni from one of the PERSAGI members, she also mentioned the same thing. So weighing the benefits and the disadvantages that you mentioned in your presentation, would you recommend prescribing plant-based diets for them? And if so, perhaps how much of fruits and vegetables that the dietitians can recommend to the doctors? Thank you.
Okay. Thank you very much for very interesting and up-to-date questions regarding the practice and also interest in renal nutrition. Yeah, definitely. As I mentioned just now, our main obstacle when you try to implement about plant-based diet and main concern would be hyperkalemia. So I think that is what restrict us from actually involved in very much about plant-based diet. But I think you have to look into what the latest study and try to put into the context, about your patient situation. We know that, I'm not sure about in Indonesia, but in Malaysia we have a national health and mobility survey that is being conducted every 10 years. And the data is reporting that, our general healthy population is not even meeting the requirement of dietary fiber intake. Basically, what is saying that majority of our healthy people out there is not even meeting the requirement for fruits and vegetables intake. And yet, you are worried about our dialysis patient eating excessive amount of fruits and vegetables intake, which is very unlikely. Yeah. So it comes back into the comments just now. How do you then incorporate plant-based protein diet in your patient situation. But again, you have to put this into your own practice, your own setting. You have to determine in the first place, is plant-based diet is typical to your patients. Yeah. You don't want to suddenly change all the protein into plant-based diet, because a sudden change then wouldn't be good as well. You may want to increase gradually. First, you need to try to meet the requirement for at least the requirement for fruits and vegetable intake as well. We are talking about 5 serving all in together with fruits and vegetables in a day. So if you can't, if patient can't even meet that, so it's going to be challenging. Yeah, because I'm sure that in Malaysia and Indonesia culture, we are not coming from the vegetarian culture like in India. In Malaysia, we have a population of Indian population which is very much following some vegetarian diet, so it's pretty easy for them because they already get used to it. They can actually adjust, in a meal. They make sure that there are some beans, there are some combination of vegetables that can make sure that it's meeting the essential amino acid requirement. So I think that's the first step that you can do. Just trying to meet at least the recommendation for fruits and vegetables first, and see gradually how it affect your overall patient nutrition status, and check. Of course, you have to monitor their biochem gradually, yeah, to see on that aspect. Okay.
Thank you so much, Pazu. I'm going
Maybe
to.
Pak Yudi is better because he can talk from your perspective.
But I think you mentioned a good point, and I'm going to speak in Bahasa to make sure that our attendees understand what you said. So jadi Pak Zul menekankan bahwa sebetulnya nggak hanya di Indonesia, tapi juga di US, di Malaysia banyak sekali, bukan hanya pasien, tapi kita orang dewasa biasa itu jarang yang betul-betul memenuhi kebutuhan buah dan sayur setiap harinya. Beliau menyebutkan 5 cups of serving buah dan sayuran setiap harinya. Nah, jadi kalau misalnya kita menebak-nebak nih bahwa pasien akan melebihi rekomendasi itu justru jarang terjadi. Jadi seharusnya tidak disarankan untuk menghindari buah dan sayur, tetapi secara gradual, secara bertahap disarankan untuk menambah porsi buah dan sayurnya sesuai dengan yang biasanya mereka makan. Jadi itu bisa juga untuk menghindari konstipasi. I think one of the attendees also asked that question in the chat box. Okay, I'm going to go with the next question, but Mas Yudi, do you have any additional information on the fruits and vegetables?
I think Dr. Zulkifli recommended to eat a fruit and vegetable 5 serving per day. But in Indonesia, about the protein intake that have been mentioned using the source of plant-based protein intake, it can be increased gradually, and we can start it with give the patients with low. Not low in dialysis patient, we can start with 1 grams protein per kilograms per day, so we can increase it gradually to 1.1 and 1.2 to the target of the patients with dialysis gradually increase. That's Ms. Nurul for the plant-based protein source. And in protein source, plant-based usually contains high of potassium. We have to consider the potassium intake in plant-based protein, in especially Indonesians or Asia usually eat like tempeh and tofu, for example, as a protein source of plant-based. We can also consider how much the plant-based of tempeh and tofu can be recommended to the patients with the dialysis, CKD with dialysis. That's Miss Nurul.
Thank you so much. I'm going to go with the next question, but I think it invites answer from both of you. So the question was on, there's a dilemma between whether we have to fulfill the calorie intake first or the fluid intake. So this one is from Rizka Mitasari. It was for Dr. Winnie, but I think it's relevant for both of you as well. So which is more important to be intervened between patients non-dialysis with malnutrition? Should we give intervention to repair malnutrition with giving high-calorie diet, or intervention to maintain the kidney with giving low-protein diet? Who would like to answer first?
Universe.
Fazul, go ahead.
I can answer. Right. Okay. So it's a very interesting question. So if I can understand it correctly, correct me if I'm wrong. So your question is that whether there are two scenarios here, whether you want to how do I say, emphasize, or you want to prioritize on the malnutrition issues facing by this CKD patient, or you want to embark into the low protein diet. Am I right? Is that what the question is about?
Yeah, so the patient is non-dialysis. He is malnourished. So usually if it's malnourished, we go with higher calorie diet, but then the kidney is failing. So should we instead pay more attention on the low protein?
Right, I got it. So the idea is based on the recommendation. This recommendation is actually based on the previous study that have looked upon into the nutrition status of this patient as well. So the lowest amount, because you are talking about CKD, yeah, CKD 3 to CKD 5. So the lowest amount of protein, that you can actually give to the patient for non-diabetic is at this 0.55 gram per kilogram body weight in order for them to maintain neutral nitrogen balance. Okay, if you go lower than that, so that means they started to experience imbalance in their nitrogens, and they started to, our body started to break down our muscle tissues in order to get more protein, in order to sustain the daily protein requirement. So that's the idea. So your issues just now, how about if patient is malnutrition? Yes, if patient is malnutrition, you still can work on, to give at the higher end of the protein intake. Yeah, in at this point, you can go up to 0.8 gram per kilogram body weight if patients like severely malnourished. Yet you make sure that the calorie requirement is actually meeting his need. Yeah, so I think there's no issues there. Yeah, so you can increase the calorie requirement, but those calorie requirement, where is it coming from? So it can come from either carbohydrates, it can come from additional fat for this patient. Yeah, maybe Pak Yudi want to add on?
Yeah, same as Mr. Zulfitri's answer. Yeah, we have to consider the renal function, the metabolic condition of the patient, the catabolism of the protein of the breakdown muscles that can lead to increasing the ureum in the blood and the patients, and becomes the blood of the patients becomes too acid, so the patient can be in high risk of acidosis of metabolic. It can happens in malnutrition patient. So the target is through 0.5 to 0.8 grams per kilograms body weight, which we have to monitor the patient energy intake 35 kilocalories per day. In Indonesia, we usually use we are usually 10 not 10, so we are usually give the patients with CKD, because of the restriction of the protein intake, the snack with high of energy and carbohydrate, such as what we call sugar candies, for example, cotton candies, for example, and using and we are also give the patient with honey, for example, and traditional snacks that less of the protein intake, such as, for example, talam ubi, for example. Yeah.
Yeah.
For example, like snacks like that to increase the patient's intake of energy and calories.
Is sago?
Yeah. Sagu too can be also give as snack to the patient.
Yeah, you can give a sago gula melaka.
That's nice.
Okay, so I think the gist that I get from both of you is doing a middle ground. So still trying to get the intake of protein, at least at the minimum of that our muscles are not breaking down, or the patient is not breaking down, but also fulfilling the energy intake to make sure that they can perform daily activities. Okay, so we are going to the next question. I'm not sure if this is going to be the last question because of the time. But this one is also interesting because it's quite clinical question, but I think it's relevant also. There is a kind of a dilemma about it, because often, like you mentioned in both of your presentations, that patients with chronic kidney disease is also experiencing other chronic disease, such as type 2 diabetes and other morbidity. So this question is from Vina Dina. She is asking about a patient with chronic kidney disease who is also on type 2 diabetes and using nasogastric tube. So this is an interesting case. So if the hospital is using commercial product for enteral nutrition for the NGT tube, right? There's no specific products for patients who have both chronic kidney disease and type 2 diabetes mellitus. So the dietitian have to choose which one. Is it the enteral nutrition for chronic kidney disease, or is it the enteral nutrition for diabetes mellitus? So which one should she prioritize? Would you like to give any advice? I will go with Pak Zul first, because I think the case in Malaysia might be different situation, and then we'll go with Mas Yudi, maybe more practical what's happening in Indonesia, or with the source that we have in Indonesia.
All right. Okay. Okay. Patient on nasogastric. In this case, is diabetes. It's typical because about 60% in Malaysia, 60% of CKD patients are diabetic anyway. Yeah. So this I presume this could be critical. I'm not sure about the setting. Is this outpatient setting, or that's patient already at home, bringing in with the long term it's unlikely. Usually long term they use PAC tube instead of nasogastric. I'm not sure the case, but I presume, let's say this is inpatient setting. Inpatient setting meaning acute cases, right? So in acute cases, we don't really, what we are concerned about is as long as the patient could actually meet the requirement in terms of protein energy. In that case, giving kidney-based or renal-based formula is much easier. because it's concentrated and it can easily meet the requirement of the patients. And in hospital settings, when it comes to the hyperglycemia, that can be easily managed by, insulin titration. Doctors can do that. So we don't really have issues that if patients have diabetes in the first place. Yeah. Maybe Pak Yudi have a different perspective from Indonesia management.
Yeah, thank you, Mr. Zulfitri. Yeah, in Indonesia, okay. Based on the question, which patient it is, CKD pre-dialysis or dialysis patients? Because in management in CKD pre-dialysis and dialysis is different, both on in patient with diabetes mellitus. Yeah, Miss, who's that? Miss Nurul Valentina, yeah. Yeah, which patient this is, CKD pre-dialysis or CKD with dialysis? Because in CKD, with pre-dialysis, we should give the protein restricted, not more than 0.8 grams per kilogram per day. But in CKD dialysis with diabetes mellitus, for example, this is, I assume it is a hemodialysis patient, yeah, which is used to have the restricted in enteral fluid, yeah. The patients should be give using the energy and high protein dense fluid. We can make it in our hospital. We can combine it with some with adding for example eggs to increase the protein. And also for the literature said that for the renal formula it have to meet a 1.8 kilocalories per milliliter. But in Indonesia itself, there's no formula with renal formula that meets the recommendation 1.5 kilocalories per milli. And there is a specific commercial formula. It only achieve 1.6 kilocalories per milli. So in this patient and in these conditions, we have to see the patient's conditions. For example, the patient have been restricted in fluid, for example, 700 milliliters per day. So we cannot give full to the patient with energy 35 or protein 1.2, but we can give it gradually to the patient. We consider the patient condition, which is, for example, in critical ill, we cannot proceed the patient with dialysis. Oh, the patient with dialysis, so we should have to give the patient protein 1.2 grams per kilogram per day. Not like that, but we have to see the patient condition in holistic and in general, because of the restricting of the fluid recommendation intake from the patient. And we can also recommendation to use the parenteral nutrition, for example, by the intradialytic parenteral nutrition, for example, to increase the protein intake to the patient. So despite using of enteral nutrition, we can also using the parenteral nutrition if the patient condition is unstable, for example, and the gastrointestinal tract it cannot be accessible.
Thank you so much. So I think it's quite complicated if you try to understand it, but from what I get from both speakers is that there is really no clear-cut answers to this question. So we have to monitor. I think this is the key message. We have to monitor the patient. So you prescribe certain diet to the patient, and then we have to monitor, does it work or not? I think that's on Pak Zul and Prof. Winnie presentation, that monitoring is quite important because we have to see whether it works or not, and then we have to wait 1 day, 2 days, and then 3 days. If it's not working, then we have to change into another prescription, or we have to adjust making the condition of the patients into better situation. I think we are running out of time. Right now it's 12:47 Jakarta time. I would like to thank you, Pak Zul and Mas Yudi, for the time and the discussions. I think the attendees are also having a really good time learning from both of you, and Professor Winnie. Unfortunately, she cannot make it to the discussion, but I know that there are many questions that are left unanswered in the chat box and also on the YouTube. But I think PERSAGI will help with that after the webinar is over. Perhaps Pak Zul and Mas Yudi can answer that afterwards. And with that, I would like to end the Q&A session. To sum up today's webinar, I think there are three main important points. First, we as dietitians have the role to prevent worsening of condition of the chronic kidney disease patients. And it is important because we aim to delay the onset of dialysis therapy. And then because we know that there are many complications usually with the chronic kidney disease patients, we have to prevent and manage complications. And last, we have to maintain optimal nutritional status, just like Pak Zul, Prof. Winnie, and Mas Yudi has mentioned throughout the webinar today. Okay, thank you so much, Pak Zul and Mas Yudi. I would like to give the stage back to Mbak Deas. Are you here with us?
Yeah, wait.
Yes. Ms. Nurul, I'm here.
Over to you.
Okay, thank you, Ms. Nurul Asma Ahmad Tarmizi, for being today moderator, who has guided the material presentation and Q&A section, as well as to the speakers for the amazing presentation. Now it's time to give the certificate to the speaker and moderator. The certificate will be given by Mr. Sugeng Eko Irianto, MPS PhD. First, I'm honored to invite Mr. Sugeng Eko Irianto, MPS PhD. You may give the certificate to Mrs. Professor Dr. Winnie Chisiwi, PhD, as the first speaker by virtual presentation.
Okay, thank you. Good afternoon, all the participants. First, on behalf of the organizing committee, I would like to give a certificate of appreciation or a certificate award give to Professor Dr. Winnie Chi from International Medical University of Malaysia as a speaker during the international webinar of dietetic update on chronic kidney disease on Wednesday, 23rd of March 2023, signed by Secretary Indonesia Health Workforce Council, Dr. Muhammad Budi Bidat Kemenkes, Chairwoman Indonesian Nutrition Association, Ms. Rudatin SKM MP MSc, and Head of Indonesia Health Workforce Board, Dr. Trihono MSc. Again, thank you, Dr. Professor Winnie Chi, for your valuable contribution.
Thank you. Next, Mr. Sugeng Eko Irianto, MPS PhD. You may give the certificate to Mr. Dr. Zulkifli Azwan Daud, PhD RDN, as the second speaker by virtual presentation.
Okay, next is a certificate of appreciation give to Dr. Zulkifli Azwan Daud, Associate Professor from University of Putra, Malaysia, as a speaker
during the international webinar of dietetic update on chronic kidney disease on Wednesday, 23rd of March 2023, signed by Secretary Indonesia Health Workforce Council, Dr. Muhammad Budi Menkes, Chairwoman, Indonesian Nutritionist Association, Ms. Rudatin SKM MP MSc, and Head Indonesia Health Workforce Board, Dr. Trihono MSc. Thank you, Dr. Zulkifli Azwar, from your valuable and inspiration from all of us. Thank you.
Thank you. Then Mr. Sugeng Eko Irianto, MPS PhD, you may give the certificate to Mr. Yudi Arianto, SGZ SA MKM IVO, as the third speaker by virtual presentation.
Certificate of appreciation given to Mr. Yudi Adrianto, SGZ MKM, dietitian from Dr. Cipto Mangunkusumo Hospital, Jakarta, as a speaker during the international webinar of dietetic update on chronic kidney disease, Wednesday, 23rd of March 2023, signed by Secretary Indonesia Health Workforce Council, Dr. Muhammad Budi Menkes, Chairwoman, Indonesian Nutrition Association, Ms. Rudatin SKM MP MSc, and Head Indonesia Health Workforce Board, Dr. Trihono MSc. Thank you, Mr. Yudi.
And last, Mr. Sugeng Eko Irianto, MPS PhD, you may give the certificate to Ms. Nurul Azma Ahmad Tarmizi as the moderator by virtual presentation.
Certificate of appreciation given to Ms. Nurul Azma Tarmizi as a moderator during the international webinar of dietetic update on chronic kidney disease on Wednesday, 23rd of March 2023, signed by Secretary Indonesia Health Workforce Council, Dr. Muhammad Budi Menkes, Chairwoman, Indonesian Nutrition Association, Ms. Rudatin SKM MP MSc, and Head Indonesia Health Workforce Board, Dr. Trihono MSc. Thank you, Ms. Nurul.
Thank you to all participants. Now we will hear the continuity plan from Indonesian Nutrition Association and Indonesian Health Workforce Council will be read by Mr. Sugeng Eko Irianto, MPS PhD. For Mr. Sugeng Eko Irianto, MPS PhD, time and screen are yours.
Please share the RTL. Yeah. Secretariat, please share the screen. Yes. 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 Okay, good afternoon, all of you, all participants. Before we close the session, I would like to share about the follow-up of action of the nutrition of the international webinar of chronic disease, kidney disease, 20th of March 2022. The first is after we follow the presentation from three of the party resource person or speaker, we would like to improve or improvement of awareness among nutrition and dietitian on nutrition problem of the patient of chronic kidney disease. This is through education and counseling. How nutritionists and dietitian can provide nutrition education and counseling to the patient or the community, how to prevent the chronic kidney disease. The second, improvement of clinical competency among nutritionists and dietitian on how to educate the patient through continuing education and research. Actually, the Ministry of Health and Badan PPSDM will be provided e-learning, yeah, collaborate with professional association, including PERSAGI, how to do the continuing education, and of course research. I think for the research, all the dietitian and nutrition can collaborate with Poltekkes or university who has student sometimes sent to the hospital for PKL and PRAK and other activity. Then the nutritionists can collaborate with them to do research. The last is improvement of the capacity on nutrition care process among nutritionists and dietitians at the health facilities, puskesmas and hospital, and also in communities on medical nutrition therapy or MNT among chronic kidney disease patients through development of technical task force or group among nutrition dietitian, and also chronic kidney disease patient group or something like WhatsApp group, where dietitian and nutritionists can give like education. I think this is 3 of the follow-up action should be follow up. I hope all the participants, my colleagues, nutritionists and dietitian can follow up with at least 3 activity in the future. For the short term, we are DPP PERSAGI and SD will support you, all of you. Whenever you like set a proposal, we can facilitate. And of course, you have to collaborate, not individual case, but with sometimes with Poltekkes or university or hospital base. I think this is our follow-up action. Hopefully, in the future, we can meet again with other term. And of course, we hope Dr. Yul Fitri and Pak Yudi and also Prof. Vini, sometimes we still invite you in other event, not only online platform, maybe sometimes we invite you visit to Jakarta on other city in Indonesia. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Mr. Sugeng Eko Irianto, MPS PhD, for reading the continuity plan. And now we will hear the closing speech from Dr. Muhammad Budi Hidayat MKes. For Dr. Muhammad Budi Hidayat MKes, time and screen are yours.
Ya, terima kasih untuk moderator. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, Om Swastiastu, Nama Budaya, Salam Kebajikan. Alhamdulillah, kita panjatkan puji syukur Allah Subhanahu wa Ta'ala, Tuhan Yang Maha Esa, karena pada saat ini kita telah melewati dan kita telah melaksanakan webinar series ya, bagi teman-teman dari OP PERSAGI, ya mudah-mudahan acara ini membawa berkah dan rahmat ya bagi kita semua ya, khususnya teman-teman PERSAGI dalam menjalankan praktik ataupun berkegiatan profesi sebagai tenaga ahli gizi di Indonesia. Dan terima kasih kepada para narasumber baik dari luar negeri maupun dari dalam negeri, dan juga terima kasih kepada Ibu Dirjen yang telah membuka acara ini dari tadi pagi, dan kita doakan Ibu selalu dalam keadaan sehat, ya, dalam kondisi selalu dalam lindungan Allah Subhanahu wa taala, Tuhan Yang Maha Esa. Dan juga kita harapkan acara ini terus kita laksanakan di kesempatan yang lain yang dalam rangka untuk memberikan edukasi atau pencerahan bagi kita semua, khususnya untuk teman-teman dari PERSAGI di dalam melaksanakan tugas di lapangan. Lalu juga kita harapkan semoga nutrisionis, dietitian, serta tenaga kesehatan lainnya untuk dapat bekerja sama, dan kita buktikan pada hari ini kita yang sama-sama melakukan webinar dengan sukses dan lancar, dan kita syukuri bersama. Inilah adalah bukti bahwa kita bisa bekerja sama dengan baik. Dan mudah-mudahan, dan sekali lagi kami harapkan dan kami doakan agar teman-teman dari PERSAGI, baik itu nutrisionis ataupun dietitian, dapat melaksanakan tugas dengan baik, dan kita terus mensukseskan program baik itu vaksinasi booster maupun bagaimana kita menghadapi wabah COVID-19. Dan semoga pandemi cepat berakhir dan masyarakat Indonesia bisa hidup kembali normal dan selalu dalam keadaan sehat walafiat. Sekian dan terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Okay, thank you so much, Mr. Dr. Muhammad Budi Hidayat MKes, for the closing speech. And thank you for all participants who have participated in this webinar from the beginning to the end. And also for all committee who have made this webinar to become success. Before we end this event, I want to take some documentation. To all participants, let's turn on the camera and smile. Then hold it until I finish counting to 15 seconds. I will start counting. You can open the camera. Okay. We have 30 seats here. Okay. Okay. Please, the committee help to take a picture. Okay, I will start counting now. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. Okay, thank you so much for all the participants. I, Desi Andes Brenta Sadikin, as the Master of Ceremony on today's webinar, will apologize if there are any mistakes, and thank you so much for attending this webinar. See you on the next webinar. Wassalamualaikum warahmatullahi wabarakatuh.
Kami semua tenaga kesehatan siap sukseskan program vaksinasi. Bersama kita bisa untuk melindungi sukseskan program vaksinasi. Bersama kita bisa untuk melindungi diri, keluarga, dan bangsa ini. Vaksinasi, vaksinasi, semua kita harus divaksinasi. Vaksinasi, vaksinasi, untuk melindungi diri, lindungi negeri. Kami semua tenaga kesehatan siap sukseskan program vaksinasi. Bersama kita bisa untuk melindungi diri, keluarga, dan bangsa ini. Vaksinasi, vaksinasi, semua kita harus divaksinasi. Vaksinasi, vaksinasi, untuk melindungi diri, lindungi negeri. Kami semua tenaga kesehatan siap sukseskan program vaksinasi. Bersama kita bisa untuk melindungi diri, keluarga, dan bangsa ini. Vaksinasi, vaksinasi, semua kita harus divaksinasi. Vaksinasi, vaksinasi, untuk melindungi diri, lindungi negeri. Kami semua tenaga kesehatan siap sukseskan program vaksinasi. Bersama kita bisa untuk melindungi diri, keluarga, dan bangsa ini. Vaksinasi, vaksinasi, semua kita harus divaksinasi. Vaksinasi, vaksinasi, untuk melindungi diri, lindungi negeri. Kami semua tenaga kesehatan siap sukseskan program vaksinasi. Bersama kita bisa untuk melindungi diri, keluarga, dan bangsa ini. Vaksinasi, vaksinasi, semua kita harus divaksinasi. Vaksinasi, vaksinasi, untuk melindungi diri, lindungi negeri. Kami semua tenaga kesehatan siap sukseskan program vaksinasi. Bersama kita bisa untuk melindungi diri, keluarga, dan bangsa ini. Vaksinasi, vaksinasi, semua kita harus divaksinasi. Vaksinasi, vaksinasi, untuk melindungi diri, lindungi negeri. Kami semua tenaga kesehatan siap sukseskan program vaksinasi. Bersama kita